to make sure, be aware that this is a condition that we have to treat as a team with other specialties involved in the care of a patient with wounds in the foot or anywhere in the body. At least for us, treating diabetic lesions, wounds, ulcers in the feet and the legs, we have to make sure the patient has been evaluated by the vascular service, either interventional cardiology or vascular surgeons, or also being seen by infectious disease doctors in case the patient has been having infection with the wound. Because working all together is how we will try to fix or to heal the wound. When we are called to do a debridement of a wound, usually we want to remove all the non-viable or the infected tissues, foreign bodies in the wound to try to promote the formation of granulation tissue in the wound and obviously for that to So in the top, when we do the debridement, what we want to do is use the biomodern of the wound. We try to remove all the infection that we can find in any wound. We have with that to control or prevent the wound to get infected. Then also we want to expose the whole wound to make it easy for whoever is doing the wound care to take care of the wound. Like Edward was saying before, we see this wound 1 centimeter in diameter and then like 15 centimeters tunnel. That's not the wound we want to see. So we have to expose the whole thing to make sure whoever is doing the wound care make it easy for them. And also try to interrupt, to break this circle that is causing the wound to become a chronic wound. So sometimes we remove all the healing tissue or the granulation tissue that has been there for months and try to create a new pseudo-acute wound. The indication to do a debridement comes when we have an infected wound or we have foreign bodies on the wound, try to remove all the infection of these foreign bodies. And also the biofilm. Biofilm is this layer that is forming on the chronic wound. You see these shiny wounds that even they don't look infected or they don't look bad, but they just don't progress, they don't improve, they don't get better. And we just see this shiny layer on the top of the wound. It's just something that is forming with time, with creams, ointments, powder, whatever we are using. And those products form a layer over the wound. And that promotes the growth of microorganisms that can cause infection on the wound. So we have to remove all of these, including the biofilm. What method we are going to use to do the debridement? It depends on the patient. It depends on how painful it is for the patient to do what we are doing. Also, depending on who is doing the debridement, it's not the same if a nurse is doing it or a surgeon is doing it or someone trained to do aggressive, debridement of the wounds. And also the environment where you are doing the wound care. It's not the same doing a wound care in a nursing home or doing a wound care in your office or doing a wound care in the hospital. And also how urgent is doing to do the wound care. It's not the same, getting a wet, big infected wound, or those small, tiny ulcers we see sometimes in the foot or on the toe. When we are planning to do a debridement on the wound, we have to check the patient, check the family, and obviously also what the primary doctor expects from us to do. We have to be very clear, like April was saying about the informed consent. Be very clear with the patient and the family of what we are going to do. Because sometimes we just get in the room and the patient thinks that we are there to cut whatever is there, the toe, the foot, the leg, whatever. And sometimes we are just trying to clean the wound. So we have to be very specific about what we are going to do. to tell the patient, okay, we are going to cut, we're going to open, we're going to debride. I mean, debride is remove all the infection, the foreign bodies, whatever, and also make them aware that you're going to keep a big open wound, you're going to keep the size of wound, you're going to have this open wound that you will need to take care of if you want, to save your foot, your toe, or depending on the wound. And also depends on the medical conditions in the patient. Like I was saying, we have to make sure it's being evaluated by interventional vascular services, by the ID doctor, everybody involved trying to get the best outcome on whatever we're going to do. Usually we try to do a debridement after the patient has been evaluated by the interventional vascular services. We have to make sure the wound will have the best blood supply after we do our debridement. If we have time to wait for that, we will wait. If the wound is too bad that we cannot wait, we have to tell the patient, you are septic because of this, we cannot wait, we have to do this or do that, and so sorry, but we cannot wait. If the patient has problem with vascular supply, the patient will be seen by interventional cardiology, vascular surgeon, whatever. They will try to open or to improve the blood supply to that wound. If they can do it, great. Usually it's recommended after they open the blood vessels, wait a couple of days to have a better blood supply to the wound and then to the debridement. If they cannot open the blood vessels, if the wound can wait, the recommendation is to wait as much as possible to see if the patient can create some collateral to help the get blood supply to the wound. So that's something we have to deal with, and sometimes it's difficult for some people to understand. If we wait, not because we don't want to do it, because we are trying to get some, improvement on the blood supply to the wound. Yes.
I just want to say that for the channel, most of you guys that are watching on the show, they're going to be up forever. Dr. Farias doesn't have control of whether or not the surgeon, Dr. Reyes, whether or not you have blood flow, number one, whether or two, how soon they're going to do it in the hospital, the procedure, number three, if it's going to work. So sometimes surgeries are delayed, like he was saying, not because he wants to, but because it's the best for the patient, right, doctor? So we just want to bring that point home to the watchers, to the viewers. Thank you, doctor.
Now, we also have to make sure the patient has other conditions controlled, diabetes mellitus, hypertension. Hypertension is something tricky because obviously we want to treat the hypertension, but for patients with problems with blood supply to the feet, we don't want that blood pressure to be too low. The higher we can get it, healthy, high blood pressure, that will improve the blood supply, to the wounds. So it's something sometimes tricky to manage, sometimes difficult to understand also. But again, it's not good to have a patient with the blood pressure too low that will impede this blood supply to the wound and make the healing worse. I have to make sure also the patient has or to consider other medication that the patient may be taking or other conditions like immunosuppression. One of the main ways to heal a wound is using our own system, our cells to heal the wounds to form the granulation tissue. If the patient is on immunosuppression, if the patient is with some condition like cancer, transplants, cirrhosis, so those patients are naturally immunosuppressed. So we know that those patients will have problems to heal any wound. When we are going to do the debridement, we have to consider also how painful it's going to be for the patient. And we have to consider a way to prevent, or relieve the pain to the patient. We can give some topical anesthesia. That's what we usually do in any wound center. Do some spray or creams or something to numb the area. We can use local anesthesia, regional anesthesia when we are in the hospital, or even general anesthesia when we are going to do a surgical treatment. Talking about how capable is the provider to do a debridement. Again, depends on the training, depends on experience. You know, the same, someone brand new just starting, with, to compare it with someone that has been doing this for years. So we have to be careful with that, because sometimes it's just just to clean the wound. Well, yeah, you clean the wound and then start bleeding, and then you are dealing with the bleeding. Or you find that there's a pocket, there's a tunnel, there is an undermining, something, and then the thing is, what should I do? So that's something we have to consider. How urgent is to do the wound care is what I was saying, one ago, is if it's not infected, if it's clean, okay, we can wait. If it's something infected, it's gangrenous, it's septic, okay, something more urgent. So we have to check how bad the wound is, the infection, if there's an infection on the wound, check the perfusion and see if we can improve it before doing any debridement. How painful it is for the patient, and this biofilm I was talking about. Some of these, cells that are collected in the chronic wound that when we see it, okay, we see it red, we see it shiny, but okay, that's something that has been there for months, so we have to do something. So now talking about methods to do debridement. We have selective ways to do debridement. It means that just to remove necrotic or infected tissue, or non-selective. Selective is something that we just remove necrotic and infected, but also we can remove granulation tissue, we can remove healthy tissue, so it's not that selective. So obviously those are more extensive ways to write. On the selective, autolysis. Autolysis is the most common, is the one natural that we do. Our own cells do the debridement. Macrophages, we just help them to do the debridement. Like April was saying, the wound is moist, dry, the wound is dry, wetted, and that way we can create an environment good for the cells to work and do this autolysis of all the necrotic or infected tissue. Enzymatic debridement is the one typical use of collagenase to do the cleansing of this necrotic and slough tissue with the help of these creams. Also just used in the wound. If we put this cream in healthy skin, it will harm the healthy tissue. So usually to use in the wound. Conservative char debridement is just the usual debridement we do in the wound center. Just the necrotic, the scar that we see in the wound, we remove it, that's it. We don't touch anything else. Biosurgical, this is a way to call the maggots. We can use maggots to put on the wound, and that helps on the cleansing of some wounds. Usually this is used as a last resource of when a patient is not a candidate for surgery, patient has failed on other treatments, is something that has been shown that helps on the cleansing of some wounds. And the ultrasonic mist is like a Versajet used to clean the tissue on top of the wound. That's it, doesn't go deep, doesn't go in our deep. And the non-selective, the typical surgical, go to the OR, clean the whole thing, we cut the whole tissue, we remove, as I said, healthy and granulation tissue, we create a new wound for the patient to deal with and maybe have better chances to heal. Hydrotherapy, here we can include the Whirlpool, Versajet, all those flushings that we do with antibiotic, BASH, all those solutions that we can use to clean wounds with pressure, with just irrigating the wound. The wet to dry is something that works, but it's not the way we are used to do it. This is putting a wet gauze. Wet is not soapy wet, it's just moist the gauze on top of the wound, waiting for the gauze to dry, and then remove the dry gauze. If we start putting solution, saline, water to moisten and remove it, the effect is gone. The effect is dry, and just pull it out, and you will remove the whole thing. If you wet it, then you lose the effect of this. So you have to let it dry, and just let it dry, just take it out. It's painful for some patients, that's the thing. Now, the way it will work is to change it every 4-6 hours, not 2 times or 1 time a day. So that's the other thing, is when you take in consideration the time and all the, the resources you use to do it 4-6 times in a day, so it's not that cheap as some people think. So that's something you not to consider, and the correct way to do it is not, that easy to do. And the surgical charge agreement is the one, like the first one. It's just remove the hole with scissors, knife, everything to clean the wound. Talking about the specific one, the neurolysis is the most selective because it removes just necrotic or soft tissue or infection, usually done by our own cells and neutrophils and macrophages. And we have to make sure, like I said, it's a wet environment for a dry wound or a dry wound for a wet condition, and have a good blood supply to make sure all these cells can get to the wound. So it comes with improvement on the vasculature to the wound. The thing is, it's slow, it takes time, so we have to be patient with it, okay? So on the left, we can see a wound before we do this cleansing or this debridement, autolytic debridement. On the right, the wound is looking cleaner, and now it's getting also healing better. The enzymatic one is the collagenase cream that we use that helps on the breaking of all these necrotic and devitalized tissue. The thing is, we just have one option. It's an expensive one, so it's sometimes not affordable for some patients. But the thing is, it's good and very effective, so we have to balance. And this is more specific, and the thing is, what I mean with secondary dressing is, like, when we put a sandpill, for example, or collagenase cream.
That's why I have my own private Confrence, because
Okay.
You're the same brand.
We usually put the cream and we put like a moist gauze on top. So that's the secondary dressing. The moisture helps the cream to work better. Next one. Here we have a wound without before starting the sandpill, and then on the right one we have the sandpill with cleaning all this bad tissue. On the conservative debridement, is just to remove what is very obvious that needs to be removed, or we can remove. Again, the usual debridement we do in the wound center. The dry scar, we just cut it out with a knife, with the scissors. The callus, sometimes we remove the callus around it. That's it. We don't deal with more. We don't cut more because we may have bleeding, we may have some more issues. Obviously, with that, we can expedite, the healing of some wounds because we remove already some of the vitalized tissue, and that will help on the formation of the granulation tissue faster. And this now we're starting to deal with the wound. We cut, cutting, removing. That can become painful or not so comfortable for some patients. And this is just removing some slough with a knife, and then usually in the office or in the wound center, no problem. That's it. That's all we do. The biosurgical is the maggots we were talking about. This is good when it's indicated. So far, I think I've seen 1 or 2 patients with maggots in 15 years. So it's not a common condition, but it's an option in case it's needed. We have the little guys there working. Have to make sure, have to contain them in the wound. So there's special bags or containers to keep these maggots in the wound. one of the main complaints of these patients when they have it is that they feel the warmth, walking there. So that's why you have to try to contain them in the wound where they don't have that sensation, they don't feel them. Okay. And the use of this ultrasonic mist, this Versajet, usually, even though we can do it in the office, with all the spread of the mist all around, it's better to do it in separate, usually in the OR or somewhere, not to get everybody contaminated in the office here. This is the Versajet that we use, and again, we just pass it on top of the wound and we clean just the superficial part of the wound. Here's a wound before the Versajet and after it's more shiny. And on selective, on the surgical, again, it's removing everything around. Your cut, knife, scissors, boom, everything is out. These some of the things we may use.
Gracias. Yes, sir.
QF usually helps to clean like the bottom or the base of the ulcer or around the margins. But again, it's better to expose the whole thing. If we have undermining, cut all the skin on top of that space. That way we have it exposed. And again, is thinking in who is going to do the wound care. When I see patients in the office that they send them after having an IED of an abscess in the ER, and they send them and they have this tiny cut with the packing on the bottle of the quarter-inch packing inside. It's just to do that. Who's going to do it? My wife is going to do the wound care. Wow. Good luck, because it's difficult. So it's better. Sometimes it's more drastic, but it's better to have a big open wound exposed, able to do the wound care. You can see it. You can see how is it looking, how is it improving or not improving. That way you can go and check and see what's going on. Next one. When we think of taking the patient to the OR, when the patient is septic, we see an evident big wound, infected, painful for the patient. If we can try, or we try to do it in the office, the patient just, cannot handle it, it's painful, or it's yelling, or okay, hard to want to take it to the OR, for you to sleep, I think it's okay. If we find or we see there's some undermining, some tunneling, again, it's not good to deal with that. It's better to open, expose it, and have it better for the wound care. So all of that is better to do it also in the OR. That way we can cut, we can remove. The main thing, if we have some bleeding or some problems with what we find, sometimes we find bone exposed, we find tendons. So it's better to have in a good environment where we have all instruments to work with, and not to get a surprise in the office or in the wound center. For the hydrotherapy, I mentioned the Whirlpool, not much in use at this time. Basically, was used on burn wounds. I think the top center they use it for burns. The Pulsivac and the jet lavage, basically to clean the wounds with pressure, with the water and pressure to try to remove infection or the vitalized tissue. The thing is, with this pressure, we can inoculate the organism if there's an infection. So the organism can get into the blood system and then cause sepsis or cause an infection or a reaction to that. So this patient, after we do some of these debridements, may have fever, may have acidosis, so we have to be aware of that. This is the Pulsivac that we should do. The wet to dry is what I was mentioning. Have to change every 4 to 6 hours to make sure it works like it's supposed to work. And again, we don't have to put any water or something to remove the gauze. So it's just dry and just boom, out. That way it's the way it will clean. It will take out everything what it stick to when it will get dry. I removed moist, now dry gauze. One method that we want to use depends again on the condition of the patient, type of wound, where is the wound, how deep is the wound, and also how painful or how is the sensation of the patient in the area. We know that traditionally diabetics don't have a good sensation. They lose sensation, and sometimes we can even cut a toe and they don't even feel it. So it depends. So there's the other way around. Patient with arterial ulcers, these arterial ulcers usually are very painful, and we just touch them and they start yelling, complaining. So those ones we have to be more careful and maybe get the patient to the OR or somewhere to get anesthesia and make it more comfortable for them. The thing is, if we are going to do something, do the best thing we can do, not just clean on top because it's painful and I will leave it like that, or almost the same as it was before. You have to cut, you have to cut. If you cannot cut it in the office, okay, take it to the OR. You have to remove whatever you have to remove, okay? And again, depending on who is doing the debris. Depends on the training on every person doing or working on the wound. When we clean the wound, we start seeing a healing wound. We start getting some granulation tissue. The wound is not infected. We have the vascular guys already work on the vascular supply, and we have the best conditions for the wound to heal. And we just see that the patient is like going slow and not getting too much improvement. Even we can try to work on helping the wound to get more granulation tissue. And then we can start using all these products that we, like Dr. was saying, every day, every week we see a new product, a new powder, a new graft, something. When we have many things on one product or one condition, is because no one is saying. Everybody wants to tell you that their product is the best one, okay? It's a Friday, that's the way. So, what works for me is the one I will use. Okay. So this is like all antibiotics. You have a bunch of antibiotics out there. You work with antibiotics that you trust. It's the same for this. You start working on all these products. You stick to the one you see they are working for you. Okay. We still don't have like a good study to see which one is the best. So at this point, everybody wanna tell you this is the best one, this is good for this is good for that. Again, show me the data, show me the paper, show me the information where I can say this is best or this is better than the other one. Let's see, we still don't have that one. We have all the theory, we have all the information behind, how they think it's working and it's improving or it's getting the wound better. But we still don't have something really, scientific to tell this is the best product for a wound repair. Well, so we have a wound, it's not improving, it's good, it's healthy, but EOC is like the same. So we can now we'll try to improve the formation of granulation tissue. We can start dealing with some products that are based on collagen and the formation of collagen. And these are some of the products we have available in the market. Endophrine, Pura, Oasis, Primatrix. All of them, we have them all around. And some, a good option to start treating these ulcers. They are good, all of them have a good, results. And again, you are going to choose the one you get, more confident, you trust better, or whoever you have available. The thing also we work in some hospitals, and you have to work with whatever you have, what they can offer to you. You know? Then we can also, after trying this product for a while and see that the wound is, again, staying the same, not showing any progress after some weeks. Another option, then we can move to drugs based on growth factors. These growth factors, again, they are good to promote the formation of granulation tissue. The one we have available, Epifix, Amnofix, Ranix, Enushil, Anoexel, all of them have the same effect, and again, is to promote the granulation tissue. Those, granulating wounds that are just the same and the same and the same. We can try this and see that will give the last push for the wound to heal. And the other options we have is products cell-based. These products are based on cells that will promote formation of keratocytes, epithelial cells. Some of them are from a living tissue, like amniotic membrane, placenta, like the appligraft, the affinity, the allopage. Some others have been preserved and worked with to promote these, like Stravix, Teraskin, Cryoport, or Dermacyte. Again, we work with whatever we have available. Now, sometimes for the hospital, it's difficult to see that they work different and they are, different options for a wound. And they just want to give you like a cheaper one or the one they have available, and that's it. You ask for something else and they tell you, well, we don't have this, but we have another. That is a completely different kind of working, mechanism that we want to try on this wound. Then we have adjuvants to help on the closing of the wound, the wound back, the HBO, the offloading devices, and some others like use of electrolytes or electromagnetic forces or things like that, some other stuff. I think that's it. Have any questions? Sometimes like Kepler was saying, this is much of seeing the patient and talking with the patient, because it's not the same to go and see a toe with a ulcer on the tip of the toe that is looking red and that's it, with the callus, or a toe that is all black, swelling, the swelling extending to the foot, extending to the ankle, and with the patient with fever, leukocytosis, and all the evident sepsis. Because, I can tell the patient I want to clean the wound in the toe, and we try to clean the toe. But the other patient with toe infection, I tell them, I can clean the toe, but I'm not sure if I can save the toe, And again, we have to, when we talk to them, my option is, okay, I will try to save the toe, but if I cannot save the toe, I will try to save your foot. And if I cannot save your foot, I can try to save your life, So that's something we have to make clear with the patient. And sometimes also to give them the information for them to start thinking about. If I see a young diabetic patient that has been dealing with an ulcer for 6 months, 8 months, and then he's admitted with that ulcer infected, an ulcer on the foot, and the plantar of the foot, and the foot, whatever. He tells me, okay, I've been having this wound for 8 months, and it's the same, and now we're infected. And he had already the vascular evaluation, and he's been on antibiotics for I don't know how long. I can go in the wound, do the treatment, open whatever, make it bigger. You have a wound that has not healing in 8 months. I want to get it bigger. I'm not sure it's going to heal in another 8 months. You're young, you're working. I can go And instead of opening the wound, debriding the wound, giving you a bigger wound, why don't we want amputation? Sometimes it's too drastic, but it's something we have to, to make the patient aware. I can go, cut the foot, a BKA, instead of dealing for months with an open wound that you won't be able to walk, you will be, having stay on a wheelchair, on a scooter or something. We do the amputation, your wound heals in a month, 3 months you're on a prosthesis, and you're walking again. So it's something I have to, talk with the patient. Sometimes it's difficult, but sometimes it's more practical. Actually, some of these products are used, the ones coming from the amniotic the products, that's the base of the healing, of the formation of this granulation or cells that promote the granulation tissue formation. They're supposed to work on stem cells, and because they're coming from amniotic membrane or placenta, usually more basic cells like stem cells that are promoting all of these. Yes.
Really important for the show, and it's not working. We need ahí está, ya quedó. Very important for what the doctor's saying is what he's saying for the show. We're running. It is not my children. They're on emergency bypass. So if my children are texting or calling, I'm hearing it. It is on a patient by patient basis, and you have to talk to the patient. Like he says, there's patients that are not going to heal unless they get an amputation. And some patients are like, yeah, I'm young, I'm going to be walking to, I'll have a BKA and then I'll get on a prosthesis. But it's on a patient by patient, and that's why the team that we use, they're gentlemen, and we really appreciate them. Dr. Jose Farias, surgery and wound specialist. Thank you, doctor. Where's your office, doctor? Lindbergh, McAllen. Dr. Jose Farias will put it on the link. Yes, sir. Of course, yeah. Well, hold on. You're going to speak about you, ¿verdad? Because I'm going to give you your testimony. Yes, good to see you, doctor. Thank you. Es que lo estuve esperando mucho. We have a patient here that's going to share his testimony. But we're gonna have you share right after Dr. Reyes. I know you guys have to be ready because he has a surgery. And I want to hear what he has to say real quick. He's going to do it in 5 minutes. No se crea. Véngase, Dr. Reyes. Thank you, Dr. Michael, for allowing us to take a little time slot there. I appreciate you. We had a little bit of trouble with my wonderful fiance. Fixed it, but it took us a while. And I was like, let's just go get the adapters. Because everybody has Macs or PCs, and we don't. Some people have USBs. And like, Lori, I'm going to give you your pointer. Let me give you your pointer. Dr. Reyes, introduce yourself, Dr. Reyes. You have to show up here.
Hello.
Thank you, doctor, for being here. Clap.
Clicker. So I am Luis Reyes. I'm a surgeon here in town. I'm a director of obesity surgery at the Heart Hospital. And as a general surgeon, I do take care of a lot of wounds and unfortunately amputations that we have here in the Valley. Needless to say, unfortunately, our Rio Grande Valley has been, for the third year in a row, the fattest city in the United States. So if you think how many cities are in the United States, and from those thousands of cities, our city, and it is the region, McAllen, Mission, Far, Edinburgh. It is definitely a concern. Now, on top of that concern that we're dealing with obesity, we're dealing with a new bundle of diseases called diabetes, because obesity and diabetes come kind of one-to-one together. And all these affect us significantly because most of the wounds that we see have a problem, which can be diabetes, can be obesity, can be renal failure, can be something that is going to affect the wound. So I'm going to talk very quick about just more simple things that Dr. Farias had the burden of. because he had the burden of all these new fancy treatments and creams and a bunch of stuff. I've been practicing for 25 years, and I see them coming and going. And I've seen practices coming and going. I've been working with Ms. Lopez for many, many, many years, and she's still here, and she's still taking care of patients, and we're still able to help her patients, where I see many people that don't. And most of them is because it's not that they don't have the data, it's because there's no data. You know what's the only data? Is patients do not want to lose their extremities. And then it doesn't matter what they offer them, they will take it. And they will think that we are offering them the best, and sometimes it's not. Sometimes we bring these expensive medications with a bunch of promises and a bunch of studies that are made by the same manufacturer of the product, biased in their favor. But you'll have to have the same wound, the same problem, the same infection, the same comorbidities of the patient, and compare it in order to see if it works or not. So it's so difficult, and that's why there's so many products out there, so many medications, and unfortunately, yes, it's to make money out of our patients. So I want to go to something a little bit more simple, and that is, what can we do to improve our wound healing? Yeah, just go ahead. So most of the problem that we find in the wounds is that they don't heal. A wound should heal in about 4 to 6 weeks. And if it's not healing, Dr. Farias will try to go and clean the wound, because most of the time it's infected. Most of the time it has dead tissue. Most of the time has to be topically taken care of. But let's go back to what's happening in the body of this patient. And if I have a patient with diabetes or renal failure, or the patient is smoking, or there's no good nutrition, or the patient is obese, then I have a higher burden in order to heal this wound. And if I don't take care of any of these problems, it's going to be very challenging for me to be successful taking care of these wounds. So, diabetes, 37 million people have diabetes in the United States. The Rio Grande Valley, 35% of the people that we see, the adult people, are diabetic. So the high blood sugars lead to tissue hypoxia, so there's not enough oxygen to the tissue. That impairs the creation of more blood conduit. So there is no blood that gets to the tissue. And if there's no blood that goes to the tissue, there's no delivery of inflammatory product, there's no delivery of healing products, there's no delivery of antibiotics. Basically, it is what impairs our ability to heal a wound. Now, there's a lot of advices that we've had, but most of the time, what we want to be sure is that our patients have a control of the diabetes where the hemoglobin A1C is below 8. If we can accomplish that, then we will be able to get a better situation to get the patient to heal. Right now, there's a lot of medications that are in the market, but most of the time, the chances of being able to control the diabetes of a patient, it's important. Now, we have really awful problems when we have patients with renal failure. Renal failure, which again, it comes with diabetes and comes with other situations, affects the wound healing because there's edema, there's a lot of fluid every time in all the tissues. So if we don't take care of those tissues, if we don't dry them from that fluid, things are not going to heal. The uremia, which is toxic to the environment. Now, dialysis, great invention, great stuff to clean the blood. But unfortunately, with the dialysis comes washing of proteins, washing of vitamins, washing of minerals. And if they're not supplemented, then instead of getting a healthy renal patient, we get a very unhealthy renal patient. Risk of infections are higher, and yes, unfortunately, the mortality after somebody starts in dialysis, 200 to 300 more when they become septic. So it's a major concern to have these renal problems. The nutrition, if we see everybody here and we start taking blood products to see what is your albumin, what's your pre-albumin, what are your vitamins and minerals, most of the people here are going to find out that they're not as nourished as they think they are. Yeah, unfortunately, we are not accustomed to get the right amount of protein. We go first for the carbs, the sugars, all that thing, and then if there's a little space, we get the protein. The fat, which we thought it was the bad stuff, it's not the bad stuff. But either way, if we don't have a patient that is well nourished, the healing process is not going to happen. So the first concern is that the immunity, that mechanism of protection that the body has when we have a wound, will not be triggered appropriately if we are malnourished. Glutamine, arginine, methionine, cysteine, all these are amino acids that are very important for wound healing, and if we don't have them, there's nothing we can do to improve the wound healing. Even though we hear a lot of vitamins and probiotics, and well, if you turn the TV at 3 o'clock in the morning, man, you learn a lot of stuff. Everything that they sell, everything works, everything's gorgeous. They come out in bathing suits, and I took this and I took that. The elements, the vitamins that have proven to be important in wound healing, zinc, iron, vitamin C, vitamin A. Those are the things that we need to be sure that our patients have supplements, because if for whatever reason they got diarrhea, then they're losing. If for whatever reason they're not eating appropriately, then there's a problem. If for whatever reason they're not having the appropriate diet. So this is where you think, okay, the treatment of wounds has to be complete. Listen, you cannot just go and open the vessel, or you cannot just go and clean the wound. If there is no basic structure where your body can help you to heal, things are not going to happen. Now, I do treat obesity. Unfortunately, as I started saying, our Rio Grande Valley area is one of the most obese in the whole country. And if the United States is one of the most obese countries, then our city is one of the most obese cities in the world. This is, for many reasons that we still don't understand, a huge concept of why is it that people gain the weight. We don't know. We really don't know. Genetics, excess on calorie intake, socioeconomic problems, and we can blame each one in a different scenario. Well, people don't know how to go and buy. Well, some people don't have the access. We call those deserts, food deserts, where there's no way to go and buy vegetables, fruits, something. They just have the 7-Eleven that they go and they buy Cheetos. but it has to be chile, it has to be, it's a vegetable, maybe. So we can rationalize how we can eat or not eat and find our food. We don't have the right education because everything in the marketing world is how am I going to sell something? And I'm going to tell them that it has less calories because that's what sells today. And I'm going to tell them that it is not that bad, but it's very good. And then you also see all those ads that eat all you want and lose weight. Doesn't go that well. So the problem with obesity is that the risk of infection doubles. Because when we have adipose tissue, which is the fat that we know, there's not a lot of blood flow there. So if there's not enough blood flow, it's the same thing. There's no enough delivery of nutrients to heal a wound. There's not enough delivery of antibiotics to take care of the infection. And it takes longer to heal that wound. Not only that, but even just think about the physical burden of the body. When you have an open wound, and then the tissues don't stay there because of gravity, and they're so heavy that they just open. I wish I could just tell our patients, think about your weight. Think about the burden of your family when they're going to have to pick you up and take you to the restroom or give you a shower. Think about how they're going to do it. Is it easy? No, it's one of the most complicated things in the world, trust me. We're still thinking, this is all genetic? This is all some situations in the brain? There's been data that it may be related to gut bacteria. There's so many things, but what we know is that obesity is killing us, and we need to do something. So the wounds have greater tension, they impair the wound healing, collagen deposits are impaired. As an overall, if we don't help our patients to improve their overall health, and one of it is by eating appropriately and exercising and living a healthier life, we are not doing the whole treatment. Just like Ms. Lopez said, we have to treat everything, not just one little thing. And you're going to hear from our sports expert that is another thing that is so important. So, needless to say, I don't want to amputate legs, but sometimes we have to do it. And even that needs to heal appropriately. And even that, it's easier when patients are not obese. If there's something I can leave you is 85210. That's not my phone combination. 85210. 8 hours of sleep. 5 servings of vegetables and fruits. No more than 2 hours of screen. 1 hour of exercise. And 0 sugar. 0 sugar. So when they served that beautiful cheesecake today, I saw that dopamine in the room was but anyway, let's be conscious. It's difficult. It's so difficult. Once, many years ago, somebody in Austin criticized specifically me because we were doing surgery in patients with Medicaid to lose weight. And they said that I was taking the money of the state. because it is a self-inflicting injury and people should just not eat too much. It is a problem, but it's not the main problem. There's so many things that we don't understand. There's so many things that are involved in gaining weight. The only thing we know is that it's not healthy, is that it doesn't help our wounds, that it doesn't help our patients. And we have to do the best effort we can to help patients to get educated on eating healthy and exercise and living a healthier life. Thank you very much for
I want to say something about the way that one of our team members from our surgical team. He and Dr. Farias have an office, so we've been through the ups and downs of them being with a group of a big hospital group, and now they're back in their own private practice. But throughout the whole time that they've been helping me with my cases, they've always had the same common denominator. They're patient advocates and they're gentlemen. They respect the patient and they support the patient's right to make the choice. And I really love the obesity aspect because he said this, but I want to make something clear. Does fat heal? When we have a wound, and then they get mad at us because they have abdominal wounds, and then they're open from here to here, the adipose is like that much. And then that doesn't heal. The fat doesn't come together. And so I had to learn the hard way about that, and remember that the fat cells don't do well. There's also been a lot of studies about the obesity and the fat cells, and that there's even a higher risk of cancer. Mm-hmm. There's been studies, and how can fat cause cancer? The cells mutate. We need to just decrease our overall obesity rate. I'm going to tell you this story. Dr. Luis Reyes, where's your office? McAllen, Lindbergh? Okay, in McAllen. And we're going to put all those links in, and we're live on our channels. But I'm still upset, and I'm in denial about the fact that I have to lose 50 pounds. Look at me, Dr. Reyes. I have to lose 50 pounds. And as a Latina female, I feel like I'm going to lose all my curves, and I refuse to do it because I have gained this weight and I've earned this weight. And no. There's fat deposits here in the back, in spots, and my knees can't take it. If you want to look at healthy patients, they're thin. I talk to my patients that are at the right weight, which to us Latinos, we think this person is sick, está enfermo, estás bajando mucho peso. And I ask them, do your knees hurt? Why? Because I keep having knee issues. I'm too heavy. 175 for 5'3", I'm 50 pounds overweight. And it sounds very drastic, but Marco, my fiance, is always like, usted no se va a ver flaca cuando baje 50 libras. You're going to look better, you're going to feel better. You're not going to look, because we don't realize where the fat hides. The fat hides in places you're like, I didn't even know I had fat there, but fat hides everywhere. So we really appreciate, I love that. So it was 8 hours of sleep.
8, 5, 2, 1.
8, 5, 2, 1. 8 hours of sleep, 5 servings of vegetables.
Less than 2 hours.
Less than 2 hours of screen.
1 hour of exercise.
And 0 sugar. That is something, I'm actually very good at that now, guys. I do not. Do I eat sugar? I do not. I don't. Do not eat sugar. But right now, I haven't eaten. I'm also not crazy. I always fast till 2. I love doing the fasting. It helps me. Then I eat super clean. I eat protein. I eat greens. And I usually don't eat past 7 just because it's heavier. But if I do, I have I have high protein always. 5 servings of protein. I do a lot of collagen. I do not touch sugar. My coffee is black. So right now I've had 3 little chocolates. I am fasting. So I also have to have some green. So no estoy loca. But I do not recommend sugar. I don't have candy in the house. 0 sugar is not a sin. But when we hear 0 sugar, Dr. Reyes, oh, what do you mean 0 sugar? That's the takeaway. Thank you so much, Dr. Reyes. We love you.
Thank you.
God bless you. Patient testimonial. Because, I didn't even remind this patient about today because I told you guys I have 3 or 4 very frail patients that if I tell them they're going to be here, and come over here, sir. This man is always with me. He is also a pastor, so he's going to preach for an hour. Introduce yourself. Hold on, I'm going to fix your wheelchair. he could be walking, but he's being over confined. Did he break anything? Oh, because he already had it fixed. What happened to you?
Buenas tardes a todos. Gracias por esta oportunidad que tengo. Esa luz.
No, I'm gonna put you on. Move it. ¿Ya le das la
Ya. Ahora sí nos vemos mejor. Quiero decirles una cosa. Mi nombre es Roberto Guzmán. En la edad tengo 71 años. Sí. Que ando ahorita en una silla de ruedas es nomás porque un día me levanté de mi ubiquera para ir al baño. A la mitad del camino me caí sin saber, sin tropezarme, sin nada. Me levantaron la ambulancia, me llevaron al Heart Hospital, me atendieron, me reemplazaron, me pusieron un fierro con tornillos y aquí estoy nuevamente adelante y estuve en un Royal Cliff, un skill facility por 100 días. Gracias a Dios he comenzado a caminar. De allí venía con esto porque tenía unas heridas. ¿Cuántas personas han tenido heridas? Otra pregunta. ¿Cuántas personas han sanado de heridas? Una cosa, todos podemos sanar si le damos la oportunidad a alguien que nos guíe. Hace 5 años yo estuve en el Heart Hospital. Y entonces ahorita ha habido 5 cirujanos que han querido cortar mi dedo, mi pie, mi pierna. Y me han challenged that they will do it and I will call y ellos tienen que hacerlo, que me decidan. Gracias a mi April, ella me ha dicho no. Uno de los últimos cirujanos de allí de su oficina salí casi con lágrimas porque mi pie estaba negro y querían cortarlo. Y mi hija decía, papá, yo tengo el teléfono personal de mi April y yo le voy a hablar allí afuera de sus oficinas. Y allí hablé antes de subirme al elevador y dijo, April, no, yo me encargo de usted con la ayuda de Dios, pero sobre todo el equipo de su familia que lo ayude para que pueda usted sanar. No es una persona, no soy yo, es tu familia que te apoya, que te ayuda, que te saca adelante y mayor que todo. Te dicen de algo así muy extremo que está pasando en tu vida, no mires para abajo, mira para los altos. El salmista alzó sus ojos a los cielos de donde venía su socorro. Así nosotros como mexicanos, ahorita que estaba hablando el doctor Farías, mi respeto. Estuve 7 días, una semana en el hospital de Heart Hospital, salí de allí y salí con mis pies morados. April lo vio, dije yo, April me va a curar y ya está todo. Cuando ella vio, dijo, no. Levantó sus manos, en esto yo no puedo hacer nada. Pero ahorita le voy a hablar a un doctor que es mi amigo personal, que lo va a atender, si no es ahorita eran las 2 de la tarde, si no es mañana. Se hizo el appointment, otro día en la mañana, ahí estaba yo. Me dice el doctor, dice, esto está muy mal. así era como hay los Q-tips, no sé cómo les llaman, así era largo, lo metió por el dedo gordo y salió por la planta del pie. Dijo, aquí hay no una choza, hay una cueva. Así es de que, dice, aquí está la orden, vaya para atrás al hospital, luego voy para allá y hacemos la cirugía. Le dije, estamos en la epidemia. Acabo de salir una semana y regresar para atrás. Dije, no puedo. Dice, aquí no lo hago porque allá está la anestesia. No. Y dice, a menos una cosa. Digo, ¿qué? Si aguanta. Dije, soy mexicano, todo aguanto. Y comenzó. Una herida de 7 pulgadas del dedo gordo hasta la mitad del pie. Mis size de zapatos son 13. Me quedaron nomás 5 pulgadas que no cortó. 2 pulgadas de ancho, 2 pulgadas para adentro. Los tendones estaban en el aire, el hueso del pie se veía. Y les digo una cosa curiosa, si el doctor está aquí, le doy gracias porque él me ayudó y por esa razón aquí estoy ahorita. Cuando terminó, él no pensaba que yo podía aguantarme, me aguanté. Porque aparte de ser nosotros unos, si confiamos en Dios y Él está con nosotros, sabemos que todo lo podemos hacer. Y como mexicanos, somos bien machos. Y si no, pregunta el otro mexicano y dice, yo también soy bien macho. Les digo una cosa, todo ese proceso ha caminado, y para hacer reír al doctor Farías, si está por aquí todavía, cuando terminó y cortó todo eso, nomás mi hija estaba conmigo. Y le digo al doctor, ¿qué va a hacer con eso? No, ya solo sirve. No, hombre, le digo, dámelo en un papelito y me lo llevo y hago una fajita de ahí frita. Uno, del dolor y de todas las circunstancias, trata de agarrar algo, como decimos en inglés, you need something to hold on. Y el mejor testimonio, busquen a Dios. El Salmo 41:1 dice, oh boy, el que piensa en el pobre, Dios lo bendice. Bienaventurado es persona porque es feliz pensando en alguien más. Estos doctores piensan en cada uno de nosotros. Y muchos de ellos se van con sus lágrimas para la casa, porque necesitan buscar a Dios para sacar adelante y ayudar a aquella persona. Dios les bendiga, gracias por este tiempo, y como dice April, todavía me faltan como 35 minutos más.
Mr. Guzman has been through so many wounds with us. I already lost count. I forgot about that big one with the tendons. I'm like, that's true. He's had black toes. He's like, no, but sometimes I can and sometimes I can't help. So we get our team. Dr. Michael's going to talk about mobility. Let me use him as an example. He wants to show you his feet. Praise be. This is our foot right here. Glory to God. No, and then he comes back, the BP was black. Initially. Yeah. And then he comes in with wounds all the time. I'm like, you need to stop getting wounds. No more wounds for you. But I'm going to tell you, that's what I was going to say. There's patients that heal from one, they have another. Look, he has wounds right here. I want to see you when you have wounds like this. Please, can I see you when you have wounds like this? I don't want to see you when you already have a black toe. Right? So, Dr. Michael, come up here, Dr. Michael. This is a perfect time for Dr. Michael to come up because we have a patient here who who had a hip fracture, and he had a surgical repair of that hip fracture. A ver, Papa, how do we do it? We put it up here? Ganarle, pero I pick this up. Hold on. There we are. Te vas a pegar aquí. I'm going to cause another one. Okay. And therapy is very, very important for patients like this. Mobility. So he's going to talk about mobility because we don't want him to get atrophy of the areas that he's not moving, right? So I want to introduce Dr. Michael. Tell us a little bit about yourself. And we're going to understood, right?
Is it on yet? There you go.
The last thing we need is a fall.
Seriously.
Okay, but that is very important because if he doesn't move, then he's gonna get stuck. There it is. Going to get stuck. Okay, let's load up the slides. And
Hello, so my name is Dr. Michael Ibarra. I go by Michael. I'm not a medical doctor. I have a clinical terminal degree. It's in a doctorate of athletic training. So to be clear, I am not a personal trainer. I am an athletic trainer. So a raise of hands of anybody that knows what an athletic trainer is. Okay, yes, so I'm going to educate you guys. So we'll go ahead and we'll move on to the next slide. So presentation overview, what is an AT? What is mobility? The healing process, Wolff's Law. What impedes healing? Research review, some articles that I found, some of it not being the best, but just what's available. Muscle contractions, movement engagement, and discussions. We are going to discuss some of the cases that you guys have, and could movement potentially influence or be influential to those cases that you guys have had in the past? And then, of course, questions. So we'll go on to the next slide. So what is an athletic trainer? What is that? So you guys, how many of y'all here have kids that are in sports? Right? Okay, so somebody gets hurt, you're at the school, right? And then they get down, they're on the ground, oh my God, I hurt myself. And then you see somebody running out there. Boom. That's an athletic trainer. That's traditional athletic training. I am a non-traditional athletic trainer. For me, working in the secondary school setting wasn't really where I found a lot of passion. However, here in the Valley, we do have an industrial athletic trainer. We have somebody that works at GE Aerospace, out right by the border. And what she does is she takes care of the employees that are there. She takes care, making sure that they can continue to do their jobs. They repair jet engine parts. So as an athletic trainer, what she does is she educates them on their bodies, right? Hey, you know what? My neck is hurting. Why? Because you're doing this. You're down here and you're fixing this for 12 hours a day. What do we need to do? Maybe raise the table, pick it up, get your posture a little bit better. Is there any way that we could load off the weight from your wrists, your hands, your elbows, your neck, things like that? So we have an industrial athletic trainer here in the Valley, along with multiple high school athletic trainers. Now, what I do is I have an athletic training coverage contracting company. It's literally called Athletic Training Coverage, AT Coverage to be short. And what I do is I staff athletic trainers in areas where they don't have ATs. There's so many schools here that don't have ATs, y'all. That means there's so many kids, so many athletes, so many events that are going on where they don't have any medical coverage. So that is a really big problem. That's called non-compliance, right, with UIL. So it's a really easy sales tactic. I'm like, do you want to be non-compliant for another year? You don't, right? We want to be compliant, right? So hire us. But anyway, that's ultimately the goal. And I've kind of gone in, we heard about April, my grandfather and I, from a really great friend of mine, Erica. Erica,
we don't need to know.
but she's amazing. I'm sure a lot of people here know her. Erica, what's her last name? Anyway, she told me about April. She's like, you gotta go see her. She's like, you and her are exactly the same. And I was like, you think so? And then I met her and I was like, oh, okay, no, we're gonna be friends. And then from there, boom, we just clicked. And she took really good care of my grandpa. My grandpa couldn't be here, but she took really good care of him and told me to present. So we're gonna go ahead and move on. So what is mobility? The ability to move or be moved freely. So everybody stand up. Everybody get up. All right, yes. Okay, bring your arms up.
We gotta exercise, people.
Good, hit it to your friends. Good, bring them out in front of you. Let's move the shoulder blades, arms forward. Good, bring them all the way back. Bring them back here, keep it squeezed. Good, and if you can, bring it behind your back. So a lot of us, right, maybe some of us are here. That means, I guess what, you're gonna do this. Okay, relax, good. Right here. So, here. You see how my arms are straight? That tells me I have good mobility, good movement in my upper body, right? So go ahead and let's move the wrists. Good, go the other way. Good, hands down, let's move the neck. Good, other way. Shoulders, let's move the shoulders. Good, let's go forward. Let's do some trunk twists. And everybody sit down and up for 5 times. Let's go for it. Good, on that 5th one, you're going to stay seated. And you're going to bring both legs out in front of you. So you're going to stay seated. You're going to bring your one at a time. Good. Easy movement, right? Let's bring our legs all the way up. And let's point the toes. Let's bring the toes toward us. Let's circle, right? Let's go the other way. Very good. And now keep your toes toward you. Let's rotate the legs. Easy movement, very easy movement. Relax. So mobility, movement. Okay, movement. People with wounds. Those individuals that have wounds, we don't want to load them when they have a wound, right? Because clearly that's going to put them in a situation that could potentially make the wound worse. But we can have them do non-weight bearing exercises. We can have them move their joints and we can still contract those muscles. And when we contract muscles, it's kind of like a pumping mechanism. We get blood flow, oxygen, nutrients toward that area. Of course, we want to be mindful. We're not trying to stress them out with strenuous activity because that will delay the healing process. But we're trying to give them movement that is pain-free and that is safe. Basic movement. Healthy movement. Pain-free movement. Can I get a nod? Right? We can all agree to that. Okay, sweet. So, active range of motion. That's something that everybody just did. You actively move, right? So this gentleman right here, active range of motion. Passive range of motion is when I'm moving you. Okay, passive range of motion is when, Michael, I'm an external factor that's moving you. That can be done by a towel too. I put a towel around my foot and I bring it up. That's passive. I'm not actively doing it, but something else is doing it. Okay, we can move on. So the healing process. 3 different phases. We have the inflammatory response, fibroblastic repair, and maturation remodeling. And the goal is to create, as a practitioner, our goals are to create an environment that is conducive to the healing process. We're not trying to put our patients in a situation that's going to make them worse. That's called malpractice. So we want to make sure that what we are doing is conducive to the healing process. We want to make sure that, again, we're talking to the patient. My grandfather, his main goal, I want to walk, mijo. Mijito, I want to walk. I want to walk, I want to walk, I want to walk. So our goal, yes, is to heal his wounds, but ultimately the outcome that the patient wants is what? He wants to walk.
Is he walking?
He is walking. He is walking in a controlled environment, but yes, he is up and he is walking. So that's their outcome. So how do we get there? We start off very small. Ankle pumps, right? My grandfather had a lot of wounds all around his lower leg, kind of like shin area, his calf, a little bit on his feet, or quite a bit on his feet. But we were able to be mindful and controlling in his treatment process, you know, with April's wonderful help, the management, the team. I mean, it was phenomenal. It was very inspiring for me, you know, to see this. So, very educational. So, to be clear, with these phases, there's never a beginning point or an end point. They all overlap each other, right? It's just kind of broken down into 3 different phases, so we can move on. So Wolff's Law, what is Wolff's Law? Bone and soft tissue will respond to the physical demands that are placed on it, resulting in remodeling and realignment. And the goal, progressive and controlled movement throughout the wound healing process. If they are able to move, that doesn't mean balls to the walls, like, sweat. No. Controlled movement. Healthy movement. And everybody say it with me. Pain-free. Pain-free movement. All right, let's move on.
Doctor, I'm going to interject here. For all the people watching us, whenever we see something so important, so important, and because it's happening to me, there is this is not working. Dígale, jefe, que me traigan uno que sirva porque va y viene. ¿No se trae otro? We have a problem. All these people doing training online, and all these people making money off your monthly online training, and you gotta lift heavy, you gotta do it, you no pain, no gain. We gotta stop thinking about that, because those of you that know I have a social media show, I need you on it. Fridays, because only important information is shared there. It's free, okay? It's always free advertising, but I want to promote what's good. And I hear a bzz, so this one's not working as well either. I want to promote good information. People need to know what this gentleman is teaching. When did you last hear pain-free movement regarding exercise? Have you heard that? I've never heard it. I've never heard anybody tell me, is what you're doing for health? Or are you competing? Even if you were competing, how many of y'all know that a lot of these big bodybuilders fall over dead? Because they're injecting their hypertension, they don't check their wellness, they don't do all the anticipatory guidance, and guess what? Their spines are so messed up from the heavy lifting that they would rather get a surgery and then stop lifting and competing. Mr. Olympia is in a wheelchair. I'm not going to say his name, pobrecito, but he's in a wheelchair. Do you know what the man is still doing? He's still lifting. So I think he really wants to mess up his C-spine so he could be a quadriplegic. I mean, let's be honest. And I lost my train of track earlier, doctor. There is where we also need therapy, I think. Because we want to look good so bad. I love the way my body is now. I built so much muscle. I've built a different shape, and all I had was a tummy tuck and a little lipo. She can vouch to that. But because I literally had all these hanging, and it really offsets your back, and we talked about adipose tissue, so we don't want that. There's nothing wrong with plastic surgery. There's nothing wrong with training. The reason I wanted Dr. Michael here today is because he impacted me so strongly that I was hurting my body in an effort to make it better. And nobody's telling us this. You know why? Because I was never told, you need rest days. You're 46 years old. Hold on. Everybody needs rest days, or young kids are going to tear their knees. Bodybuilders, I'm sorry. You're on all these different uppers and all these fat burners, and then your pressure's real high, and you want to lose fat quick, and you're doing all these very drastic diets, because y'all know when you go to shows, you're super dehydrated and everything, you have kidney injuries. And nobody's telling us to have therapy about moving in a pain-free way, because then what would happen to me is the pump. Guys, if you've never lifted heavy, there is an addictive property, just like to plastic surgeries and everything, that when you lift heavy, those last 5 lifts, there's whoosh, like you feel like your head's gonna explode, because there's such a pump that I would go to the gym 7 days a week to feel that pump, and that is a mental problem. Now I have to tell myself, and my fiance would always tell me, Mark, like, usted está levantando muy pesado, you're lifting too heavy, the form is not right. And then I would see him work out, and he was like lifting was it 10s babe or 15s? I don't know what he was doing. 15s. And my baby's super hot, and I was like, in his back, and I was like, how are those muscles getting like that with 15s? And he's always trained, he wasn't wrestling, and I could see all the muscles popping up. And I said, now it's form versus weight. He's gonna tell us that. I want you to expand on the pain-free movement, because There's the phase and a craze, and I don't think it's a thing among athletes, especially bodybuilders, I think, that go hard, go fast, go the pump and everything, and then you're hurting yourself. So I went and got all these MRIs, and there's C-spine issues, there's T-spine issues, there's L-spine issues. At what point in my lifting did I get those? My knee, all my tears. At what point did I think it was okay to work out through the pain with no rest and not allowing my 46-year-old joints to heal? What we're watching on social media, and this is why I have a show. Now I'm gonna rub people wrong, all the trainers. Stop telling your clients, because guys, again, I'm gonna sell you if I sell tacos, I'm gonna sell you tacos. If I'm a surgeon, I'm gonna sell you surgery. That's why I work with a group that doesn't do that to patients. If I'm a trainer, I'm gonna sell you training. So if you miss your training sessions, I don't eat. So I want you to come in to train with me. I'm not gonna tell you your knee's messed up, you need to stop training for 6 weeks. You need to tell me I need to stop training for 6 weeks, because even he told me, he goes, I don't care if you're doing upper body. You're standing and you're lifting and it's putting pressure on your knee. And for my brain, I needed to go to the gym. So you have to think about it differently. Can you expand on that? All the people watching, it doesn't matter if you're messing up your body. That's not good for your body. Because you only have one C-spine, one T-spine, one L-spine, one right knee, one left knee. If this knee goes, young people, when you get a knee injury, please rest your knee, because you want to play football. You're going to remember when you're 20 and you can't walk and you need a knee replacement. So this is why I wanted him to come. Tell me about pain-free movement.
So pain-free movement, really it comes down to range of motion, right? So if I'm hitting a squat right here and I go past 90 degrees, right? But past that 90, I feel pain, then that tells me that I can train above the 90. I can still remind my body that it can still squat, just not past the 90. So I can kiss the edge of discomfort, just not past it, because now I'm exposing my body to that trigger of pain, right? So as we progressively and slowly train it in a controlled manner, our body will eventually allow for there to be more active movement, just like what we did earlier. If any of you guys felt pain in anything that we did, what we would do is we would just come back down with less motion. But we still want that motion to happen because your body can technically still do it, just not in a pain-free situation. Does that make sense? So we're controlling your movement, and we can train you to that, get you back to that full range of motion. I just want to do it in a controlled manner. I don't want to expose you to it and be like, let me just crank that all the way back. So understanding that when you're training, are you training for competition? Are you going to go balls? Are you going to go balls to the walls? Are we training for our health? And a lot of us here, if we're going to be exercising, guess what it's for? It's for our health. So do we have to exert ourselves? Do we have to be sweating? Do we have to be...
Yes.
Porque estás hablando bien, ¿verdad? Sí.
Movement in any situation is good. My voice is loud.
Sí, pues esos son micrófonos tan buenos.
Okay, I'll keep it up. Thank you, Mike.
So-
Can you tell me if it's just as effective though? Tell the people. Can you be just as effective in exercise?
Absolutely. Yes, absolutely. Yes. I mean, is it important to sweat? Is it important to get the heart rate up? Is it important to stress out the body? Absolutely. Should we be doing that every single day? Eventually, it's going to cause injury, right? We're overloading our joints. We're overloading our bodies. We need to make sure that we're being smart about it. So hence, talk to a professional, right? Not somebody who's going to sell you, just constant packages, but definitely somebody who's going to help you get through that process. So athletic trainers, prime example. In situations like this, it's very non-traditional to find an entrepreneurial athletic trainer. I'm almost positive I am the only one in the valley, and I can definitely tell you, I'm the only one that has a contract.
Okay, tell me, because this is a new, I don't know if it's not a new degree, but we are uneducated. I can project. We are an uneducated population regarding these things, and this is why we have these conferences, so we can do this. This is so important for us, isn't it? Because we're dealing with all these injuries, and also we're going to care to talk about why we want to heal, right? Can somebody hire, like, who can hire an athlete, for example, me?
Pensamos por
I
eso.
can invest. I
Mira,
have a
no,
child,
tráete el otro,
can
pero
assess,
por
I
acá.
have a cheerleader, I have a volleyball, basketball, everything else,
Yo estaba haciendo
dancers,
eso desde.
and I already have
Ya, entonces ya no tiene por qué preferir tan dos.
knee pain.
Unos dos.
And I just feel like there's nobody there saying, move this way, move that way, hold on, how are you doing it? And I'm taking the kids to the gym, but who can hire, say, you,
Sí,
or
pero
you
ya.
hook people up with somebody that can, we want to do an assessment,
Uno,
a preventive assessment, this is all new to me.
So the way it would work is on
Déjame
a
agarrarlo.
consultation
Encima
basis.
cero.
In your
Trátalo así,
clinics,
ya.
can you hire athletic trainers? Absolutely.
Ah, pero a lo mejor ese y
Our
aquel tiene el mismo canal,
services
pero
are not
hay que traer aquel. Tráetelo.
insurance
Sí,
sees
tráetelo.
us as technicians is a huge problem within how insurance identifies us.
Es que
And
porque
no
como la movieron ahorita. Ah,
private
bueno,
yes,
ya debe
and
conectar
no
bien.
offense to physical therapists
Por eso
whatsoever.
están guacados,
However,
¿será?
the American Physical Therapy
Vamos.
Association, they do lobbying, not necessarily against us, but
Vamos.
for themselves,
A uno,
that
a
when
uno.
there's no crossing within scope of practice, it would be a lot more beneficial to patients if we were able to treat them and be able to bill for services, but like,
¿Qué canal tiene?
right? So, this push is just to be able to kind of ground ourselves in our expertise. We're not technicians. We are clinical
Que sabes que
experts in
también
our
lo que uso, lo que uso, lo que uso.
Ese
Es de aquí, pum. Ah, más o menos eso.
Tiene que lo use. Ya no deben diferir, tiene que estar trabajando bien.
Son
ya están diferentes.
Dile que lo use. Started an outreach company, and now I'm able to make an impact on these individuals that don't have access to athletic trainers and be able to find opportunities like this that are very non-traditional, where an athletic trainer actually can have influence in wound care management, right? So, going on, what impedes healing?
They call us mid-level, and there's nothing mid-level about us.
Eso debe. Es que si me lo muevo, sí los contrato.
Sí, porque se meten al mismo
Yo
canal.
los tengo arreglados. Por eso está 1, 2. Y tengo
And
3 de
it's
4.
all about working together, right? And understanding where our
No,
roles
porque
are
no
and
hacemos
where
porque
we
les falta
fall
pila,
short.
pero
The
eso no se
most
ponía.
proactive and most efficient working relationship I have had has been
Por
with
si
the Army. To be clear, and it was at GE Aviation with my friend Erica. The most proactive and healthiest working relationship I had was with the Army. So what impedes healing? We've already discussed this more or less. The extent of the injury, a lot of swelling, edema, poor vascular supply, the separation of tissue, most importantly, atrophy, not moving the body and not contracting those muscles is incredibly detrimental to the healing process. Health, age, and nutrition, just like what Dr. Reyes had discussed earlier. So we can go ahead and move on. So a narrative review that I looked up and found their goal was to review the physiology of
Aquí voy a andar, pero
cutaneous
ya no
healing
es. Si no
with
le
an
vale,
emphasis
no
on
debe
exercise.
nada. Uno es
So
uno
what
y el
they
otro es
found,
2. No debe. Solamente que la
what they found was that regular exercise improved angiogenesis. However, in a group that was incredibly crazy with their exercises, they also found that strenuous exercises resulted in an inflammatory reaction and delayed healing. So again, controlled exercise. You think about this gentleman that was wearing his cowboy boots, right, and then going to work. Strenuous exercise is subjective. That can be different for everybody. In this situation, this man is putting pressure on his wound. He's on his foot, and whatever job he was doing, that was strenuous for his body. So not only was he doing strenuous activity, but he also had this uncomfortable pressure on his foot that delayed the healing of his wound. So what they say is moderate intensity exercise shortens healing duration and can be recommended as a complementary medicine to accelerate wound healing. We move on. In a randomized controlled trial, their goal was to evaluate the influence of exercise on wound healing, neuroendocrine function, and the stress among adults. So what they found in their exercise group, they achieved a significant improvement in their cardiorespiratory fitness, go here. And then wound healing happened at a significantly faster rate. Now this group, what they did was they did ankle exercises. So they weren't like on their feet, they were doing ankle pumps. That's all they were doing. They did it 2 times a week, 3 times a week for 12 weeks. And they encourage, this entire study encourages exercise activity as a component of medical care among patients with dermal wounds. Now again, this is all very subjective. It's case by case basis, right? Per patient. So it may not be practical to patient A as opposed to patient B. So hence you do need to consult with a movement expert to be able to understand when it's appropriate and when it's not appropriate. That way you're not putting this patient into a situation where you don't want them to be. But again, very low grade exercise, movement in general, is good for the body. We're not asking them to jump, we're not asking them to flip, we're just asking them to move their joints. And that action, even that neurological function of even just telling your body to move is beneficial to wounds because those muscles are contracting, meaning that pumping mechanism is occurring within the tissue, meaning we are getting blood flow, oxygen, nutrients to that area. So you're going to move on. In a systematic review, their goal was to determine whether exercise improves healing of diabetic foot ulcers. So we're going to move on. And they found 3,103 articles identified and only 3 fit their study. So their population was anybody that was older than 18, they had a diagnosis of type 1 or type 2 diabetes, and they had an active foot ulcer. The intervention was any form of physical activity. The comparison, what they said was just usual care, and the outcome was wound size reduction. So we'll move on. And it's actually funny because they said that there was insufficient evidence to support exercise, which is why I thought it was important to include this one. However, they do say that the results from the studies do demonstrate that wound size did reduce from exercise, and exercise did not, in any shape, way, or form, create an adverse effect on their patient. Again, strenuous exercise, absolutely. Low to moderate exercise, just movement in general, it didn't cause any adverse effects. There just wasn't enough evidence to support the actual hypothesis and their goal, which was to support exercise as a...
I'm going to interject here because I want this for the videos. We talked about evidence-based guidelines. We all follow them. We follow the evidence when we make choices. We are science-based. All of those that are higher education prepared, we understand that we have to have scientific research data and analysis. Has any of your patient that moves around and is more active done worse ever in anything? No. None of your patients have. As nurses, as nurse practitioners, as doctors, you can say that the patients that are more active do well in all things. I can say in my probably by now hundreds of thousands of wounds that we've taken care of in general patients for primary care, for the last 26 years, every single patient that doesn't move gets worse. Every single one, because they get muscle atrophy. Matter of fact, Jacob did a study, or it was one of the Jacob manics, to get the patient up and moving as soon as we can. We still forget to order therapy as soon as the patient's going to the hospital. Did you know that within a few hours of being bedridden, you're already losing muscle mass? Hours. When I read that study, I was like, oh my goodness, all my patients, PTO, TEVAL, ST, everybody got everything. So, thank you for including it, because he's clearly doctor prepared and he knows to include both sides because the data doesn't support, but we have practical clinical expertise. If you think about it, did you not feel better after he made us all move? I was like, oh man.
We all woke up, everyone's smiling.
And back to what he's saying about something that the patient can do, I feel like I'm starting to get a vision for a world where we as clinicians formulate a movement plan for patients based on their fitness level, on their comorbidities, and I'm probably going to be implementing it in my practice and just do it private pay. If they want to pay it now, we'll probably help them out, because it's not going to take that long to formulate a plan to go see a patient and help the patient. Something as simple, I can tell you, because I'm very passionate about it now because of my knee. My knee healed with no surgery, but I looked up all the therapy. I kept texting him. I did his knee for my knee healing, his program. And then I said, okay, therapy and movement, healthy movement. So in my mind now, when I go to the gym, I'm going to feel better after I finish the gym. And now when I'm doing my row work, because I'm not doing anything high impact, my knee's well enough to where I can do row work. and I can do a skier, and I can do now bike finally, but I'm not killing myself. So I'm thinking slow, steady movement where I'm feeling better. And that is what we're geared to. So I just want to say that clearly patients are going to do better if they move. When I first had my knee injury, all I could do was this. I couldn't even stand right. I kept walking on it because I had to work. It didn't hurt to walk, it was weird. But this is all I can do. Do you know this is part of the therapy for me to heal my knee? These, do not underestimate. If you do this for 10 seconds, and then I learned that I could do all these calisthenics and all these movements that I was still sore like if I lifted. So if you think about, I learned this one. There's a gentleman that has a channel. You need to have a YouTube channel. No, for real, I'm not kidding. It's not hard to get it. So I'm already sore right now. How much does my one leg weigh? So am I lifting weights right now? I'm lifting all this fat and muscle because I do have muscle. I'm already sore. So I was able to feel soreness and not gain any weight. And it's been almost a year, right, Amor, that I've been dealing with my knee. So I learned, this is already super hot, right? And so this, and then another thing that I could do in the acute phase of healing, these, how much weight am I lifting? Not locking the knee, lifting a lot of weight. So I would get real sore. And then like you told me, like, I want to use all your movement. Like you said, right? How do you say that? Pain-free movement. What can you do? So I could do this. That's a squat. I just squatted and I literally just contracted. What do you think? How do you say it? I flexed, I contracted my glutes.
But your body's thinking, you're squatting all the way, right?
Exactly.
Because the second that you're passing, your body's like, danger, danger, but if here feels good, then let's keep it.
And I did that for a long time, and it was so hard. We have to think about how we move different. And this is something very important. Very important.
So let's see. So again, just in anything, further research is warranted, right? That's how we end all our research papers. Further research is warranted. So let's go ahead and move on. So active exercise, just like I mentioned, weight-bearing exercises, in some situations it may not be the most practical because we don't want to load the wound, but some weight-bearing exercises, squats, jumping, walking, running, lifting, non-weight-bearing exercises. This is most likely where we're going to have a lot of our patients, and that's just going to be a lot of a range of motion exercises where if it makes sense, my feet right now are touching the ground. This is a closed exercise. So if I'm squatting, it's closed because my feet are in contact with something. However, an open exercise would be my feet are not touching. So what we want to prescribe, what we want to encourage is open exercises where there is no loading. So non-weight bearing, right? I can do some ankle pumps. That means my calf is working. I can do circles. I can do this. And just like what April was doing, she was lifting her leg. We can lift here. I can lay on the ground and I can lift here. I can be on my tummy. I can lift back. So there are lots of ways that we can continue to influence the body to move. So muscle contractions. So 3 different types. Concentric. Concentric meaning I have a dumbbell and I'm about to show you my super hot bicep. No, I'm kidding. And I'm grabbing that dumbbell, right? I'm shortening the distance from my shoulder to my arm. That's concentric. Eccentric is I have the weight here and I'm elongating. I'm lengthening the muscle. And an isometric, everybody sit up straight. Put your hand underneath the table, just like this. And just push up. Push up into it. The table might lift. There's a lot of you guys, right? So that's an isometric contraction. We are shortening our muscle without movement. Does that make sense? So that's where this is going to be a really safe exercise for our patients to do is isometric because we're not having them move. We're not having them shorten. We're not having them lengthen, but we're still contracting that muscle without movement. So those exercises are really going to build up some strength. We can go and move on. So discussion. Any of you guys can you all think of any situation where you feel like you may have been able to encourage movement? Yes. Okay, well, give me an example. So here's some things to think of. Location of the wound, severity. Were they immobile? Were they mobile? Maybe we could have done weight bearing or should have been non-weight bearing. So think of a case Okay? I at least want one person, not April. One person to tell me. Can you think of a case? Post-op, yeah, post-op for sure. Most definitely we want them moving, but not moving to put them in danger, of course, right? But we definitely, just like she mentioned, the second that they have a wound, the second that they have something, right, that we're not moving, atrophy is starting right away. My grandfather fell, his leg, I mean, the atrophy, you just look at it a year later and I feel bad, because I'm just like, Grandpa, I'm so sorry. Like, it's really tiny, this, that, the other, but we got him doing stuff and we're getting back on track. But even just 1 year, 12 months, makes such a significant, drastic change in how we're able to have that strength balance, right? So we need to make sure isometric contractions. I'm not asking you to move. I'm just asking you to contract. And we can all do it right here, right now. Just squeeze. We can all squeeze our muscles. That's an isometric contraction. So let's move on. So do you guys have any questions for me?
I'm freaking out about this. Do you have questions? I learned this on me. Did you see how much you felt this? Or was it just me? Like, that's literally, if you push up on the table, I feel it tight from here all the way up to here. So I could have my patients be like, nobody's gonna get hurt with this. They gotta do 10, 20. They're gonna get strong.
And you can think of it as a percentage, right? So if you go at 100%, you can feel, if you put your hand under and you go 100%, right? But then we can back off and say, maybe let's do 10%, where you're barely pushing, right? But there's still contraction happening and we can slowly work them up to that full effort of putting in 100% effort into that contraction, right? So.
Do you have any slide with your information so it can come out?
I think it's the next one.
Can you pass out the cards too?
I forgot them.
Don't worry, guys, take a picture of that. We don't need cards anymore.
There's
I love
me.
cards. Okay, do you want to get a hold of him? I'm freaking out about this. Dr. Michael, I'm so impressed. I was impressed with your energy and your aura and your love and your white light and everything and your love for your grandpa. But he's extremely knowledgeable, isn't he? Let's give him a hand. I think he was the best speaker in the whole country. Not to say anything about the box or me, but he's like, wow. And Sandra, Miss Flores is an amazing speaker. Miss Flores, she's gonna come next. She blew me away. She put us all to shame. We're not done with you, Dr. Michael. But I'm just gonna say a story. I want to talk about my friend. Yo estoy sentada. Miss Flores blew us away whenever we were in the nurse practitioner program, and she was the first one. We drew numbers, and she was the first one to present. And we were all like, it was like we were freaking out. It was our first master's, right? Our family nurse practitioner masters. And here comes Miss Flores with her. The first presenter is never supposed to be good because we all were gonna present our own. What was it? What is it called? What we did? That study, the whole research. I don't know. Was it your PIP? Your last thesis? We had to do our. It was a case study, but it wasn't just a case study. It was, remember? It was a very extensive. Marty was there. Marty heard her. Remember, Marty? We were in hell, but we're out. Praise be to God, and we're in peace. And so that's why I love Walton, because they're so good to their students. We had amazing teachers, don't get me wrong, but it was very difficult. I had a 40 farm, and I went to speak to my professors, and they looked at me and said, "This is adult learning." I said, I already had a company. Remember, I already had a company by then. And then I said, I understand that. I have a bachelor's and an associate's, and I'm pretty well versed in adult things, but I'm reading everything in the book and everything in the other book, and I have a 40 in pharmacology. This is adult learning. Go read more. I said, yes, ma'am. If you're in a nurse practitioner,
I worked in the ER, my medical center for 10 years.
everywhere. Look at me, and I'm the professor. This is adult learning. Go study more. I said, okay. So I did. But Miss Flores gets up there and she's going to do her presentation, and we're thinking, you better have A this, because, in case kids are watching, you better have A this because you're going to make us all look bad. And what does she do? She goes up there in a suit and she gives a cátedra. She did so many different research. She did more than was expected. She had all these studies, and she was the expert. I remember it was on mental health, right? Was it depression? I don't remember what it was about, but the actual thing. But I think it had to do with psych, right, Marty? And I was like, now we all have to live up to that. That's an A for sure. And now I'm gonna freak out because I have to do a lot more. So I started working on mine. And so she did me the honor of presenting for me today because I want her to be seen, and she's going to share with us her PowerPoint. But I want to impress upon everyone the fact that we don't know enough about movement. And as a matter of fact, we're not doing a good job of holistic care. We still are not. And it's very compartmentalized. And this is why we need athletic trainers, people who are knowledgeable, people who can share what they know, because nobody knows everything. And again, like I said earlier, we come to you with our knowledge or lack thereof. So I had a lack thereof of knowledge about proper movement because I thought going hard and going fast and going forever and not resting was the way to go. And you can't even do that as a child because you'll mess yourself up too. And that child that's playing football, that's going hard and dieting and doing all that stuff, that messes up their left knee, they're only always and forever going to have one left knee. When they're 30, like I've never seen one of my football player patients that are like, I'm so glad I played football. Man, I had a head injury. Y'all know about that they did a movie on that about the chronic injuries. How people were in the NFL and they don't have any, it's like a secret hidden thing that's going on with them. They have all these head injuries, because injury comes with sports, but I'm saying nobody tells us to move in a pain-free way. Everybody says no pain, no gain, go hard, go fast, and lift heavy and hard, and don't rest. You don't need to rest. Rest is for the weak. And then you end up with everything torn. I've already had a torn rotator cuff, had spine issues, my knee. But I understand, and we have to be able to be taught. And this is why we have these conferences, and we have to be able to keep up with the newest and the greatest, and whatever we need to do to help. And then you know what else? Kyle can vouch for this. We have different practitioners tell us different things. Can we stop telling patients? Example: LASIK surgery. I was told, Nambe, you're in and out, you can go to work the next day. Has anybody had LASIK surgery here? Did you do that to yourself? You were in and out, you went to work, you were driving? How did you do? I'm going to tell you. I was like, I got out of my LASIK surgery with my eyes closed. I'm not kidding. I'm like my grandma. I listen to my grandma. Y cuando te hagan la cirugía, sales, mijita, con los ojos cerrados, con lentes y tapada. So I got out of my LASIK surgery like this, not touching, not touching, not seeing. I was just going like this. I went straight home. I put my drops in. I went to sleep. I would just wake up to put my drops in. And I took care of my eyes. I didn't look at screen probably for 5 or 6 days. I'm not kidding. Is that overkill? A lot of people think it is. Okay? I did great. I had zero pain. I had zero dryness. I have zero complications. I could still see. I'm still 20/20. Okay? I have patients that come, oh my gosh, I had LASIK, but I feel like I have sand in my eyes and I've had so many come. Well, what did you do? Oh, I drove myself home. What? He said I could drive myself home. Some people drive themselves home. I don't know why they do that, but the point is, it's okay to be conservative when healing. That's the thing. Like, I'd rather you, right? Because if you were an NFL player, you had a torn abdominal wall, and nobody told you to take it easy for, how long does it take for a wound to completely remodel? 1 year. Wounds, after you've had a procedure, the wound will remodel for an entire year. What does that mean? If I've had a procedure, I'm going to take care of myself for an entire year till I'm fully remodeled, because what they tell you is, you're good already. It's been a week. You're good. And you had severe injury and that it didn't fully heal maybe because you didn't take care of yourself as much. You have to be extra careful. It's okay to do a cuarentena every time, like the old school. You want to love your body because you only have one, right? So this is very, very important. I wanted to have this up for a while. Now we're going to go. Any questions? Dr. Michael, you're awesome. Thank you so much. You're going to be welcome, Dr. Michael. I already have probably 100 topics lined up for the social media show. But if there's a pressing topic that you guys think is important, either for advocacy or something that you guys want to see, just shoot me a text on Messenger or through the cell, and we'll be happy to look at it. Ms. Flores, are you ready, madam? Okay. So we're going to put up your slides. And I always say I like to go home early. I can't believe you guys are still here. Usually by this time, I have like 4 people left. I want to leave too at this time. But what time is it in there? Beautiful. Perfect. I admire her for her intelligence. She's a strong lady. She's extremely intelligent. She's an exceptional mom. She's a Latina, so we gotta support her. Ah. So, Ms. Flores, what do you want, Ms. Flores? You have a clinic? All right. Tell us about your clinic. Where are you located? How long have you been there? How long have you been in practice? Okay, so everybody can hear you.
Okay, well, I'm glad it's after lunch because I'm going to make it short and sweet. I don't want to bore anybody, but my name is Sandra Flores. If I haven't met you, nice to meet you. I've been an RN for, how many years? I don't know. 25 years. And a nurse practitioner for how many? 10. We graduated the same. Yeah, well, we graduated from the same school, the same program, the same year. April's like my best friend. I admire her so much. She has helped me through everything. I look up to her and I thank her today for this opportunity. I practice family practice in Edinburgh at Flores Family Clinic. We focus a lot on diabetes. I can say that I'm an expert in diabetes. My diabetics don't go to endocrinologists. My diabetics stay with me. All my diabetics, I'm proud to say, my diabetics are all A1C7, the highest 7.1. But I work really hard. That's my focus, right? Of course, we can't do everything. My patients still have to go to cardiologists and wound care, and they have to go to see the podiatrist, and they have to see it's everything. We can't do everything ourselves, but we try really hard, to do a lot for them because, like we were saying earlier, we try to focus on holistic care, and that's what we nurses do. We were trained, right, to do that. So today we're going to talk a little bit about infection management and wound healing, which is very important because it's something that sometimes we don't talk about a lot in practice. Sometimes doctors don't have the time because they're so busy, like Dr. Reyes was saying, Dr. Farias. We can't say, oh, this is the antibiotic that's going to kill this bug, or this is, we have to, everybody is individualized and everybody's different. And like we were saying, bottom line, a lot of these wounds are chronic and they're colonized, sometimes like with all of this bacteria, with our own bacteria that we have on our skin. So it's important to focus on the treatment, but also individualized. So we have to also be careful when we prescribe or we recommend antibiotics for patients because a lot of them will go to Mexico, right, and get them. And this is the antibiotic this is the best antibiotic for skin, right? And we all know which one it is, right? The one that go by in Las Flores. They go by, yes, right? They go by the Levaquin and the Cipro and all that. But at the same time, what patients don't know is that sometimes we're hurting ourselves by doing that. So it's important to educate the patients and let them know, especially patients with wounds, not to go to Las Flores and buy the antibiotic because it's not just an antibiotic. Okay, so let's go to the first slide. This is a little bit about the background, and I know that Ms. Lopez wanted us to focus on the, like we said, about the antibiotics. 20 to 50% of all antibiotics prescribed in the U.S. or in the hospital sometimes are unnecessary or the wrong one, inappropriate use. So it is important that we, like we were talking about, improving the use of antibiotics is very important too, because when these patients have a wound and they've been taking some other antibiotics, there might be it might be inappropriate use, and at the same time it makes it worse for their healing. And remember, antibiotics do have side effects. It's not just okay to take an antibiotic. You know, we have to be responsible with taking antibiotics and recommending patients, because you guys are out there. You all are the first ones, right, assessing the patients. And what do y'all do? Medication reconciliation, right? And you see all these meds. It's our job to say, okay, you're on this, but you're also on this. So a lot of education and awareness and a lot of teaching, because sometimes they don't know any better. So let's go to like you were saying, right, for that when you go see them, that you find all these different bottles. Like you find a C-pack and you find.
I had a patient with 6 bottles of 100 milligrams of Tramadol from Mexico. He was giving the lady one every 46 hours. Because she had pain. He lost her. He couldn't make her.
Yeah, but I'm sure you find different bottles of different antibiotics and pain medicine. Okay, so let's go to the second slide. This talks about the Joint Commission, and this is very important because I have read about it too. Because I had to do a research study in school relating to this about the standard, and sometimes it was like promoted when we were in school. It was promoted, and then after the pandemic, it changed. Like people started using antibiotics again, but there is a standard, and if you want to read on it, it became effective right June 1st in 2017. And really, what this says is just to remind clinicians about the stewardship of prescribing antibiotics. And it's just like 7 core measures, like that we should be aware of. Of course, infection prevention and controlling the source of the infection, prescribing the right antibiotic, prescribing appropriate antibiotics with the adequate dosage, because that's also important, and then reassessing treatment after we find culture results, and reassessing after a patient takes an antibiotic. It's important too if they have a chronic wound or a chronic infection. So the next slide. Oh, this talks about C. diff. Then the deadly diarrhea, y'all have heard of that, right? Sometimes we don't talk about it, or we don't see it. Sometimes it's misdiagnosed. Sometimes by the time, right, clinicians find it or it's diagnosed, patient's already been in the hospital, dehydrated, and this is severe. And sometimes we need more awareness of C. diff infections, because we don't know that sometimes the cause of it has been because of antibiotics, or patients that have been in the hospital for a long time taking different antibiotics. So it's important that we assess for this as well, and that we instruct our patients that this can be it can be deadly, and once you get this, it becomes a chronic issue, and it's not good. How many people have treated or patients with C. diff or taking care of? Right? It's not easy. Because it's not just, sometimes they have to suffer with this for years, and the aftermath of what C. diff.
I want to just interject on this one, because the C. diff that we see a lot of times can be prevented, especially in the hospital. We see the IV, and then the patient can say, "Oh, my stomach's starting to hurt." One loose bowel movement. You gotta get on it. At home, same thing. One loose bowel movement, C. diff test. Why? Because they've been on so many antibiotics for other reasons. And then, does it also cause skin breakdown?
Yes.
Have you ever had diarrhea? It's not only uncomfortable, but it's very irritating. So it irritates all the rectal area. People get fissures. People get gluteal wounds. So
Dehydrated.
All of that.
Malnutrition.
Always probiotics. Don't forget the probiotics. They're very necessary.
Yeah, and that's something that you can also promote, that they can get over the counter. But we're trying to prevent this. That's why it's important, especially in wound care and chronic infections. We have to prevent. And there's a study that you were talking about that 80%. There was a study done by an endocrinologist journal that 80%. I just did my continuing education on this. 80 to 85% of C. diff infections can be prevented, and it costs millions and millions of thousands of dollars to treat people with C. diff. And it's happened. It happens a lot in nursing homes. So sometimes they don't know any better. Like I had a patient that was in the nursing home, and another group of doctors took over, but he was real sick and dehydrated, and it was not so much the diarrhea, but he had the foul, the skin breakdown. So I said, I told the daughter, they were like, they can't figure it out, and they already gave him this, and they already go, okay. I go, I bet you 100% it's C. diff. Have they done cultures? And she was like, no, you have a nursing home patient that has a chronic wound, that's been on antibiotics, has all these different doctors seeing him, and nobody ever ordered a stool culture. And sure enough, it was this. She called me 2 days later. Oh, Ms. Flores, he's positive for C. diff, And after like weeks of the patient suffering. So let's go to the next slide. Common sense.
Ms. Flores, not everybody orders the cultures because you have all these guidelines. And if I don't have these 2 or 3 guidelines, this patient does not qualify for C. diff test.
Especially in nursing homes.
I'm getting a stool CNS, ovarian parasites, leukocytes. I'm getting a guaiac, and I'm getting a C. diff. Every single diarrhea patient. You don't have to like me. You know who likes me? The patient.
Yep.
The parents, the family, whoever it is.
Yeah. Yeah, and in that case, when that patient of mine that had gone over to the nursing home, the doctor said, oh, it's because that lady orders a lot of labs. And I order a lot of labs. I don't know how he knows me, but when somebody says it. Well, there's a problem, and we have to find it, right? Somehow. Okay, so this is something that I also learned from Ms. Lopez because she's so smart. And I used to think before, because there was not a lot of it, that we would do it backwards, but it's actually this week, before we like, oh, you have a wound, here, antibiotics, right? What do people think right away? Or here, apply the vitacilina, or the powder, or put cream on it, or one patient put olive oil on one of his wounds. Okay, so no, it's the other. We as clinicians always think, apply antibiotic ointment, take this antibiotic. But it really, sometimes you're hurting the patient. So, and it's hard because it does take a multidisciplinary team. But sometimes, let's be honest, when a patient comes to the office or if you go to see your doctor, I see a wound. I know that wound is going to be assessed by me and it's going to need follow-up, right? And I have to send him to infection control or I have to culture the wound. But I'm not the type of person that's just going to sit there and be like, well, he's going to see Ms. Lopez in a month, right? And then he's going to see the surgeon after that. And then he's going to see infection control. Sometimes in the perfect world, our patients are going to see all these practitioners really nice. No, it doesn't happen that way. Especially here in the Valley, we're very, very, very medically deprived. Why? Because of the socioeconomic. I'm not complaining, but we have to face it. So sometimes you have to be the wound care doctor, sometimes you have to be the infection control, so that's why sometimes you have to advocate for them. Yes, you want them to see the specialist, but sometimes they're not going to see the specialist in a month or 2. The specialists are busy people too, the surgeon.
I used to be able to get an IV consult right away, but now
yes.
I'm so busy, I'm waiting 6 months.
To get me too. It takes me sometimes 2 or 3 months to get an IV code. So that's why it's important that we know, that now I know because Ms. April educated us. It's important that we do the proper assessment, and it's not just prescribing an antibiotic or putting a cream on it. We have to do the proper test. And it used to be that people just, we would just culture, right? Who remembers that? Like we culture, where the doctor would tell you culture.
I almost felt like they would tell us, right, nurses?
Yes.
Get the bad stuff.
Yeah.
Right?
Or we wouldn't even get an order. We would just, by the time you got the order, you already had the swab, right?
Yeah. So you want to swab before antibiotics, right? If they
Yes.
come in, they get antibiotics, but you just get the swab. And people will see a lot of people
Based on, yeah.
That's what we're here to learn, right?
But now, I don't do that anymore. I don't do that anymore. Now what we do is the proper way to do it is to first get a proper wound cleansing, like Ms. Lopez talked about earlier, and the punch biopsy would be the best. And if when you have your patients that you get these wounds or you see this wound, try to recommend this. Sometimes it's going to be a while till they see their wound care specialist, but this can also be done in primary care. I can do it,
comfortable, get the rec to show you how to do it, or you can have one of us, do it in our scope. Always caveat, there's always caveat, like Dr. Farias was saying. Just because you can do it doesn't mean you should do it.
Yeah.
There's a lot of stuff that I can do. I can surgically debride very deeply. I can remove bone in the clinic. It's already exposed. I can do that. I'm not going to because I don't have the equipment there. For me, that means it's a sterile procedure. Even if it's a dirty wound, it's no longer a sterile procedure. It's a clean procedure. It's still surgical debridement. I can do it. It's not necessarily what's best for the patient. So therefore, I will defer to my surgeon. And if you're comfortable doing a punch, 7 to 12 should be a punch. You want to get a good beefy red tissue.
Yes.
And you know what I do a lot? I'm already debriding, so I'll just get a good beefy tissue.
Yeah, send it to me. I don't mind doing it. And so in family practice, sometimes people say that's wound care, right? Or that's a surgeon. But like I said, do you really want your patient to wait 3 months to get this when you can, right? Get the process done.
I have to say that. She heals her own wounds. She does.
I try.
Wound care, but no, she does. She does. Because then I see her patients way later and think, I have wound care. She knows how to do wound care. A lot of us can do wound care in family care. A lot of us do wound care. And then a lot of wound healing. And then a lot of us just do wound care. And we have the lobby full of 60 to 80 patients because we get paid on volume. And we're debriding 100 squares every visit, every week. I'm sorry if I'm stepping on toes, but that is not what we're supposed to be doing. Keeping our volume up and doing a bunch of debridement because now you have a wound center. And now you have to pay your bills for the wound center, the HBO and everything. And sadly, a lot of people are keeping patients coming back and coming back. We like to heal patients out. So I'm very proud of her because she does really good with her wound.
Yes, and I send them to you. I send them to Ms. Lopez because she's an expert, but only if they don't heal, but a lot of mine heal, but because like what Dr. Reyes was saying earlier and Dr. Farias, because we address the diabetes, we're addressing the blood pressure, and we're addressing, all the nutritional. I do a nutritional panel on all my patients, and sometimes they're like, I don't do it all the time, but at least my new ones every 6 months. I check their albumin, I check their ferritin, I check folate, I check everything. And sometimes they tell me, I'm like, no, you're not eating. You're not eating 3 meals a day. You might be eating, and they're like, how do you know? Because I did it. I checked all these extra things, that sometimes, because that's important in wound healing too. Because if your patient is not eating, they're not going to heal. So, you could have like the best treatment, but if the patient is deficient in certain vitamins, and deficient in protein, they're not gonna heal as well. So bottom line, get yourself a cleaning. I always clean because that's how she taught me. And then the punch biopsy. I don't do the swab. Do you do the swabbing? No. Okay. Next.
But see, what I do is I'm here because if I'm debriding, I don't have a swab, but I'm not swabbing. I'm just cutting a chunk of the meat out. If I don't have a punch biopsy, so I just cut a piece out of a good chunk, and I literally send the chunk of meat, call it the chunk of meat, because y'all need to understand, it's just a piece of meat, a piece of flesh. Don't be sending fluids.
Yeah.
Okay? So I literally just debride off an extra little piece, and I put it on the little swab. It's all sterile, and then I stick it in the thing, so they're getting
a biopsy.
Right? And I write on the genetic biopsy. But if I run out, like I'll use whatever available tool I have to be able to send them off with it.
And it's more specific, and then by the time you get your results back, you're gonna know how to treat it, right? And now, infection versus venous stasis. This can be also confusing. I'm sure you guys have seen this in practice, where you look at a wound and you're like, gosh, and then you see all the have you ever seen all the you think it's necrotic, but it's actually all the dark skin that they have around it. So you're thinking, wow, does this person have peripheral vascular disease, right? Or do they have any other issue? But that's what we're talking about, the smoking and all that. So it's important to know, is it infection versus venous? Because sometimes they look the same, but you're not going to treat it the same, or it's not good practice to treat a venous stasis ulcer with antibiotics, right? Or anything else. But remember that usually venous stasis ulcers are more chronic and infectious. They're more acute. So sometimes you can tell here. I don't know. What do you have here, Ms. Lopez? It's
I talked about
this
this
one?
already.
Mhm.
This was just a surgical wound.
Oh, this was a
This is
surgical
not
wound, okay.
getting out of the stasis ulcer, but this is a perfect example of somebody who also never got an actual punch biopsy.
Mhm.
So they left the drain in, but they kept throwing antibiotics at it. And the surgeon did not cut the drain out, ever, never, because there was still liquid, right? There was still discharge.
Mhm.
First thing I did that visit is cut the drain and put it in. Yeah, because if you have a foreign body, you're never going to heal. You have to pull it out, and I did have one heal, but I tried to pack them. But at the beginning, the delivery is very important.
Mhm.
He's had the drain in so long, it's his comfort blanket. So, explain it. We're going to pull it out, see how you do. I already knew he needed to cut it open. I just didn't want to freak him out on the first visit. Pulled it out, started packing. If you're not better in 7 days, which he's not going to be, I need to have this open, okay? He's like, okay. He has time to warm up to the idea that he's going to have that open. Next visit, you don't have this open. But he already, all of that, you have to give the patient. Do you want a second opinion right now? No. I want you to try to help. Okay. Comes back, I know in 7 days you're going to pull out the straight. And you're looking how beautiful. You open, you read it, it was much bigger, we got the different modalities. So, this is an example of a patient also that never had a punch biopsy. We did do a punch biopsy later, so we had guided. Of course, I have infectious disease as part of my team.
And sometimes, like, it's hard. This was a surgical wound, but referring to the venous stasis ulcer, sometimes they present a little different. Okay, and the next slide, I think, is the last one. Always ensure proper follow-up, like we said. Make sure you get your, best practice. Get yourself a good punch biopsy first, and educate. Chronic wounds require a lot of education. It's not just like here, take an antibiotic and go away. It is hard, and you're gonna have to probably follow up with them. Like she said, it's not just like, oh, here, go away. It's probably gonna be a year before your patient gets better. And if you have that mentality, like, okay, we're on it. You're on it for a long run, but it's gonna at the end. I always see I love watching Miss Lopez's success stories when they ring the bell. And it looks really easy, like, they healed, right? They ring the bell. But I know how hard it got for them. It's not easy like they just rang the bell. They probably went through a whole year of, therapy and follow-up. Mm-hmm. And also you have to tell the patients, because sometimes they think, next week the wound's going to be closed.
Never. I never give patients a date. They always say, tell me, and how long did... Like, sir, you've had it for 9 years. Give me a year. You've had it 9 years. Give me a year. Okay? Come on.
Give me a week.
You probably have, some of them, like this lady, she healed real fast. I want to say this one healed probably in 10 days. I'm like, you're diabetic, you're hypertensive, you look like you have an infection. I don't know if you have good circulation. I don't know how you eat. I haven't seen your labs. I don't know yet your comorbidities. There is so many. I don't know if you move. Now we need to add this to our repertoire, that we need to, are you moving? Right, Dr. Michael? We need to go out for lunch.
Yes, and I love it because I'm not trying to say, but I've been preaching this to my patients. I've been preaching this to the choir because they come to me. Because that's what they're selling. This is what the especially in the United States, what do they sell to people? Gyms and trainers and girls that look this small. But I always tell my patients, that's not reality. You know what I'm saying? If you want to lose weight, I always tell them, don't go get us. I always tell them, they freak out because they're like, when you were talking about it, I was like, I've been preaching this to my patients, not because I think I'm a doctor like you, but because I read a lot and I've seen all these injuries in my practice. And all these injuries are because people are overdoing it. They're not educating themselves. They go and get a trainer and they work out really hard thinking like they're going to get this body. It does not work that way. I always tell my patients, do not go get an expensive membership at a gym. I'm sorry. I know you love the gym. I'm very against the gym because I'm not against the gym because the reason why I'm against the gym is because 90% of the people that go in there are not working out right.
That's exactly true.
They're abusing their body. And I lost 90 pounds just by walking. So I tell my people, and
Yay, good for
you know, as I tell my patients, you don't have to go and abuse your body. You can just walk and do these range of motion exercises. You know what I'm saying? And people are like, well, I don't know. Like, I think you're wrong. I've never heard a doctor or a practitioner say don't go to the gym. And I tell them, no, I don't say do not go to the gym. I said, you all go and spend all this money and get these expensive trainers and this expensive workout machines, but you're causing yourself injuries because they're not doing it right. They're overdoing it. So I tell them, if you want to lose weight and look good, you don't have to go and lift 300 pounds. It's easier, guys.
I'm
That's
understanding.
why
that.
I'm like, I'm gonna go can I put you in my clinic?
Yeah, we can. We got to continue to go have lunch.
Yeah.
Another thing, piggybacking on that, what Ms. Flores is saying is, do you know that when my knee was acutely injured, my babe said, my fiance said, you're not going to the gym. I don't care if you say you're going to sit in the sauna, because I was telling him, I'm just going to sit in the sauna. And then I'd come back and like, did you lift? I'm like, I just did upper body. Were you standing? Yes. Was it heavy? Yes. Okay. You injured your knee again.
Mm-hmm.
Oh,
Just by
like,
standing
it's a
there.
mental problem, I'm telling you guys. It's a
It
mental
is.
problem. You're darned if you do it, you're darned if
But
you
it's really hard, so I commend you for your job, because imagine everybody selling you this, right? What do they sell out there? Memberships and fitness and
heavy
lifting.
Don't rest.
And then for you to go tell them that that's not, that they're hurting themselves by doing that. I commend you for your job. Because you're like fighting a war, like you're like one little soldier against all this.
That's what we
Yes,
This is new. This is new to us. It's like, what? I can move. I can do this and get an exercise.
But people don't think that. People think they have to suffer and be in pain and lift 500 pounds in order to see muscle. Not necessarily. So, okay, we went off topic again, but this is where I was talking about antibiotics.
It's all pearls.
There is an antibiotic that I wanted to talk about, and I know you use it. I don't want to talk about
You can talk, guys.
names of antibiotics.
You can talk about any names of anything.
No,
This
but
is not one of those.
It's a broad spectrum tetracycline. Neisseria, have y'all heard of it? Yes, Neisseria. Exceptional antibiotic. Where is the Neisseria? Yes, you don't write. It's an antibiotic that you write all the time. It's exceptional for skin. It's a tetracycline. I'm just saying, if you see a wound out there, the wounds.
I usually use it if I can get back from DS.
Exactly. And it's not an antibiotic you give to just a patient. It's an antibiotic that, if you want to avoid hospitalization, you want to avoid Vanco, but people that have the resistance, right? We see that a lot, that they've already been on, like, oh, what else can they be on? This avoids IV therapy, and it's for the resistant, because I thought it was important that we talk about the antibiotic resistance, because we see that so much here. So these people that have had these chronic wounds, they're not going to get well on Bactrim, so sometimes you need something broad spectrum, but you don't really want to send them to the hospital. You don't want them on Vanco. They're going to see infectious disease until 6 weeks or 8 weeks, or 2 months. I'm like, I don't want my patient to wait 2 months to get on an antibiotic. They have resistance. This is a great antibiotic.
Punch biopsy. Comes back.
Yes.
Zero.
Yes.
I like it.
Especially for resistance or a history of resistance to antibiotics. If y'all want to learn more about the antibiotic, you can call me, or I don't mind. I'm not the rep, but ever since I discovered it, we have avoided some hospitalizations.
It is a good medication. And
Yes.
the other thing is, in the last...
It's a little hard to get it, but you can get it.
We can do Pyros. I do those. That's one that I'll do Pyros. I don't do it for a lot.
And I didn't want to mention names, but I was like, I
You
have
can
to.
mention all this. I mean, we're so scared.
We're so scared.
Can I say
because,
this?
like, I'm not advertising for this medicine, but you guys see these patients and something like that.
And we're here to teach you the newest stuff and all for the videos. I don't have any sponsors. We have none of these guys. I have monetary gains by them coming or them by me. We are actually here to share with you information that's gonna help you.
And then what we learn in practice, because I had to learn the hard way too. You're not always gonna have a patient that you're gonna give Bactrim to, right? In that beautiful world, right? But in our world, in the Valley world, these patients have resistance, and these these $4 antibiotics that they've been on for years aren't gonna work anymore. So sometimes you need other treatment options. There is oral antibiotics. If y'all want more information, Ms. Lopez knows I love the antibiotic. Y'all can research it. It's a
We'll
tetracycline.
put the links and
And you
we'll put
can-
her
and
link
you-
to your page.
Yeah,
too.
and you know the rep, so if you guys see a patient out there that needs an antibiotic like that, a strong antibiotic, that's a good medicine too, that I wanted to talk about as an antibiotic. Any questions? Ms. Lopez, you used it for your wounds?
Yes, I used it a few times and kept patients at the hospital.
Okay, any questions on antibiotics? You guys know everything?
The last thing, you told us everything, I love you. The last thing.
Thank you,
I wanna
guys.
say- Thank you, Ms. Flores. December 24th, regarding the antibiotics, I wanna say that you hit it and you hit it hard. After you punch biopsy, you hit it and you hit it hard. That's part of good antibiotic stewardship, because we also have those patients that we undertreat because we're scared to give them the antibiotic. You're gonna write it right. The right dosage, look at the GFR for the creatinine clearance. You have to see what is the GFR at. You may need to modify based on renal function. You gotta give the right dose, the right antibiotic, like she was saying, the core measures. It has to be the right antibiotic to the right patient in the right setting. The right dose is very important. We are underdosing a lot of times. And then we're overdosing a lot of time. Remember Cipro, 500 Q12 for 3 for complicated UTIs? It's no longer Cipro. What is it now? Those are like, it's Bactrim now. Q12 for 3. I'm like, 3 days of antibiotic? No way. That's what you do. But if they have, and now it's like no more cultures if they're what? Asymptomatic. No, it even tells you in the lab. You have positive leukocyte esterase, positive nitrates, positive blood, positive mucus, and you're freaking out. I'm like, oh, I'm going to treat the patient. Do you have any money on your feet? No. Have you had any fever? No. You don't treat. You don't treat asymptomatic UTIs. I get scared. That's the latest. And if you do treat, now, again, like you said, it's not for all the patients. I already know this patient gets septic with no symptoms of UTIs because for some reason he never gets symptoms. And then in 48 hours, he's hospitalized with sepsis. Yes. I'm going to treat him. Make sense?
Yep.
Also, your clinical gut. This patient just doesn't look good. Clinical gut is when you've taken care of hundreds of thousands of patients, touched a lot. This patient's about to code. Remember when the patient coming even on the floor, you see him and you're like, he's going to code, get him a bed. He's about to die. And he's talking to you. Yeah. He doesn't know. He has a sense of impending doom in his face. You only know that when you've seen them. And I have, it'll never happen to me again. I'm just having a little bit of chest pain. I'm feeling, be fit. So now like, you have to get him in, get him a workup, we got to get him to cath lab. Okay. We are going, is Dr. G here? You grew your hair, you grew a beard. I didn't know it was you, Doc. I kept seeing a guy that walked in. I'm like, oh, he's probably interested in the conference. So good to see you, doctor. For real, I didn't know it was you, and I could see you very well. Okay, it's so good to see you. I want to introduce to you, amor mío, Dr. Jaime Gomez. He is an interventional cardiologist. I haven't washed my hands. It's so good to see you. Good to see you, doctor. He is an interventional cardiologist, and he owns Gomez Cardiovascular Clinic, right? He doesn't look like a doctor. He looks like a 25-year-old hip guy, but he is a physician, a well-versed physician. And my brother, Ismael Lopez, works with him at his clinic. So we have his slides. Mande, mi amor. The first step. Okay, we'll do the first one and then you're going to do both steps?
Do I control or who controls?
Nosotros te lo controlamos. You want to do this one? She said, I think your assistant sent me 2. A ver.
Yeah, so.
It's the first step, right? ¿Quieres hacer esto?
There's only 400 slides, don't worry, guys.
400.
Yeah.
This one?
Yeah, perfect.
When you start referring to young guys that you don't know, you start getting worried because my original doctors that trained me in the hospital were Dr. Hilmy, Dr. Evans, the, holy grail of when they started Heart Hospital and all that. And so then came along the young boys, which was Quintana, Padula, they call them the P's in Q, Quintana, Padula, Posada. And then those guys, now they have these young kids that are, and I'm thinking, oh my gosh. And then the guys I used to refer to, nobody wants to take my patients because they're retiring or getting sick. And now I'm having to refer another generation of cardios, or me, because back then I was an RN, and they're these younger guys. And I'm thinking 4 generations of cardio, all my friends are retiring. I'm getting a little bit worried. I've been doing this a little bit longer than I thought. But they did good work. My brother worked for Dr. Hilmi for a lot of years. He did great work. Did I ever send you a patient? I never sent him a patient. I never sent him a patient. Dr. G is a visionary in the sense that he is holistic, progressive, intelligent. He practices by the evidence, but he's looking for multiple modalities. He's very into prevention and wellness. He will actually say, if you look at his page, Gomez Cardiovascular, he'll talk about the need for yoga, the need for red light therapy, the need for being happy, for heart health. I follow him, Cheryl. The need to eat well, the need to those things matter, and not everybody's talking about them. Few people are talking about them. So we're bringing information from people that actually are preventive, holistic, and are progressive. And he's got good skill. I always ask my patients, they come back and I'm like, how was he? Very good. Is he nice? That matters. Is he professional? Is he nice? Does he look like he cares? That matters. And they're always very happy with the wait time, how they get treated. I feel like they have a very holistic approach in treating patients. So we appreciate you being here, Doc. He has 2 clinics. They have a clinic in Harlingen and Brownsville. So I always give my patients a choice. I have cardio friends from, I don't tend to, sorry, and in Brownsville now I had one before I didn't have one. So I tell patients, where do you live? I live in Westerville. Do you want to go to McAllen or to Harlingen? I go to Harlingen. So and if you want to go north, I'll send you over here with my other friend. So we have people that do the work, but he's part of our team. As Doc, we appreciate you being here.
Thank you for having me. Thank you guys. Yeah, and you guys have been here all day. Am I the last one? So the 400 slides are good. I'm kidding. We won't make it too long. I have slides, but they're not that great. So let me. April gave me a fantastic introduction. So what's an interventional cardiologist? I think you guys have. Everybody here is mostly clinical, right? I imagine. So the field of vascular surgery and kind of cardiology kind of have mixed in heart surgery too. Okay, so when I was doing my fellowship way back in April said I was a kid. I just turned 50, just for fun. So when I was doing my fellowship, my endovascular surgery fellowship, I was working with a world-renowned guy, the doctor at the Texas Heart Institute, and I remember he told me, because he knew I was one of the endovascular fellows, not one of the surgical fellows. He's like, "You're wasting your life." Yeah, I was like, "Wow, what am I going to say to that?" Right? 12 years later, right? Training. Well, we do everything endovascular. In fact, we're working. It's not uncommon, and Ismael can tell you. We have a vascular surgeon, we have a cardiothoracic surgeon, and we usually, him and I, in a lot of the really complex cases, we scrub in together. Is that helpful? Yeah, because we can get the patient out alive and well. Okay, that really helps because you, instead of having 30 years experience, we have 60 years experience. Okay, or whatever, and plus we have different skills. So if he gets stuck, then I can help him out. If I get stuck, he can help me out. Okay, and who benefits the patient? So basically, our niche, and we're going to talk a little bit about this, and it's important for peripheral vascular disease. But my niche, my particular niche, I think Ismael has a niche, I have a niche. I like complex problems. That's what I do. I do complex revascularization, usually, for cerebrovascular, high risk cardiac. So, why do I do peripheral vascular? Because it can be very complex, extremely complex. It's kind of been one of these, and you guys probably, if you're in the wound care arena, you know this. PAD is kind of one of these things that everybody takes a stab at it. It's kind of like aesthetics. But when you really have a really bad facial injury, you're going to go see a good facial reconstruction surgeon. You're probably not going to go do Botox, okay? So that's kind of where we're at. Like, everybody takes a stab at PAD. The vascular surgeons, the radiologists, chiropractors, whatever, Everybody's taking, and not that they don't have a place. It's just that it's a peculiar niche, because Now, why PAD? Why does PAD get that kind of, why the heart doesn't get it, or why the brain? Well, because when you have a complication in the leg, usually the patient doesn't die immediately. So there's a little bit of a forgiveness in the leg. So I think that's part of the reason that a lot of people take stabs at it. Because honestly, usually by the time I get a referral, there's gangrene or there's an ulcer. I mean, it's kind of, or somebody's already taken like 3 jabs at it, and it's a very complex case by then. And so there's a lot of factors there that are not just medical that are going on. Now, I think that you guys have already had a vascular surgeon, right? Dr. Reyes was here. Did he talk about how common amputations are in the Valley? I think we're top 3, no, in the nation or something. Are we number 1?
He said number 1.
Yeah, we're definitely top 3. You know, the last time I looked at it, we were top 3. He might be right. We're probably top 1. Yeah. So you don't want to be top in that. It is actually, you know, it's like I tell my patients, look, do you want to meet me at 2 in the morning? No. You do not want to meet somebody like me at 2 in the morning. And I probably won't be on call, so you're going to meet somebody else that doesn't have the experience I have, or some of the guys in our team. So get checked out, you know, get evaluated before you have an emergency. So with PAD, you know, since the legs are a little more forgiving, people get referred pretty late. So I should tell patients, look, just get referred, get evaluated by a vascular specialist. If you have, well, you don't have to have gangrene, you don't have to have a wound. Many times you don't even need revascularization. I mean, I see patients all the time, you know, that they come in and they got referred for bypass, for angioplasty or whatever. I'm like, well, you walking, right? Yeah. When do you get collocation? After a mile or, 8 blocks. You do not need revascularization. You need to acclimate your leg. Like you guys were talking about rehabilitation. The leg can get acclimated to ischemia, and it's actually quite forgiving. Now, if you have a heart issue, well, okay, yes, but you need an evaluation. But many times, you do not need revascularization. Okay, we usually reserve that for the cases that will benefit from it. Because one of the things about PAD too that we have to remember is we're really good right now. The technology industry is really good at revascularizing the heart. Very good. We have a lot of really, really powerful tools. We have really powerful tools also for revascularization of kind of up in the cerebral vascular area. And we have excellent tools also for the aorta. Where it starts getting a little iffy is below the knee SFA. Like, why don't we have technology for that? It's a challenging area because there's no protection. There's no bone, or sometimes there's not even any muscle. It's kind of an exposed artery. And they're long. There's long vessels. And so what's happened is kind of all the technology that gets used everywhere else gets used in the leg. So it's kind of up to the choice of the operator. We call it the Wild West sometimes. It was the Wild West 20 years ago. It's still kind of the Wild West. So it really is operator dependent and institution dependent, and kind of how people are going to get revascularized. So that's where it's important to find. Really do your homework. Work with the specialist. Do your homework about where to send your patients, because you're not going to get the same revascularization with everybody. Just like you're not going to get the same wound care with everybody. I mean, I've seen patients that have wound care for 2 years before they get referred. I mean, what's going on there, guys? It does not happen with April, man. She'll say, if a patient just even looks like they need some assessment, and it's this thing of like you're going to lose a patient. You're going to gain a patient is what you're going to do, because you're going to help them. Okay, it's kind of a cultural thing. So, with that said, let's do a few slides. Let's see if there's anything worth talking about here. So everybody knows it's super common, right? And I'm not going to talk about venous too much, although we probably should touch a little bit on that because it is pertinent to you guys. Is it going to get worse? What do you guys think?
Oh, yeah.
Big time. Big time. Oh my gosh. Atherosclerosis, right? So what is atherosclerosis? It's PAD, peripheral arterial disease, right? What's most of the cases? Atherosclerosis. Is that helpful? It's a word that means, and most of you guys know this, it's just basically a Greek word for hardening of the arteries. Is that helpful? It's 2023, sort of, I guess, not really, right? What is it? What is it? What is this stuff that we get? It's inflammation. It's a really, really peculiar inflammatory reaction in the arteries. Why don't we get it in the veins? You know, everybody blames it on cholesterol, right? It's cholesterol, right? So in that person, when you do a cholesterol, when you send the patient to get cholesterol checked, and you're checking them for coronary arteries, peripheral arteries, whatever, the blood comes from the vein, right? Nobody's getting an arterial stick in the office, right? So the cholesterol that you're seeing in that patient is in the vein. So why does that cholesterol not destroy the vein and destroys the artery? Well, because it's not that simple. It's not just a cholesterol phenomenon. It's an inflammatory phenomenon, okay? So when you work with your specialist, with your vascular specialist, make sure that they're dealing with inflammation, okay? I mean, yeah, we can do the plumbing. I mean, we do the plumbing. We like that, okay? But it doesn't help you if I give you a patient back and then he's back in 3 months or 2 months or whatever. The patient's got to figure out why they're so inflamed, okay? Why those blood vessels are being destroyed, okay? So it's not uncommon, although I don't always do it, because sometimes the patient is coming just for revascularization. But if I get the opportunity, check the inflammatory markers, LP little a, homocysteine, A1C. I think everybody does that. How many people here check an insulin level? Yeah, that's pretty good. A fasting insulin level. So insulin levels are very helpful because these patients have it's a pretty powerful risk factor for atherosclerosis. Okay, my clients, for instance, a lot of people come see me. They're on this. Well, I'm doing my insulin shot, so I'm not going to get. Yeah, you are. You're going to get this. In fact, you're more likely to get it. Okay, I'm not saying insulin's bad. I'm just saying that it's a big risk factor. Having these high, really, if you're type 2 diabetic and you have very high insulin levels, it promotes atherosclerosis. Okay, let's go to the next slide. And you guys are welcome to interrupt, except for April. April can interrupt. I'm kidding. It's a joke. Okay, so lots of people, amputations in the valley. Yeah, we should not. Everybody in this room, I think, knows that's not a good thing to be recognized for. It's very sad to see an amputation. Anybody know what the mortality is after an amputation at around a 30-day mortality? Like death, not just complications, death. It's about 30%. So when you lose a limb, it's not just, people, you lose a limb, you get a prosthetic. It's a life-threatening event, losing a limb. It's not mild. It's not like you're going to get, you could die. Why? There's a lot of things that happen. You get inflamed. You're going to have a heart attack. You're going to have a stroke. Your blood vessels are all inflamed. Your tissues all inflamed. And then you cut the leg off. And maybe it's going to save a life, but it is not going to be easy for that patient. Okay, so it is very important to prevent it if we can, obviously. And you guys always do your best. I'm sure. We do. Okay, next slide, please. Okay, calcium. Yeah, calcium is interesting, right? Anybody here, you guys do primary care? You guys check coronary calcium scores? It's amazing, right? How much calcium people are collecting in their systems. Why are they collecting this calcium? So, when I started doing calcium scores, and we probably do more calcium scores than anybody in the valley, I think. Right? How many do we do? I think thousands. Yeah, we do thousands of calcium scores. Coronary. But I also always look for calcium in the blood vessels, because I do vascular. That's one of my niches. I do a lot of vascular imaging. It's important to note it when there's so much calcium in the blood vessels, because that is a very strong inflammatory marker. Now, it doesn't tell you everything, right? Because I just saw a smoker the other day that quit smoking 2 years ago, and she's got a lot of calcium, but she's healing. The blood vessels will heal. They don't just get rid of the calcium, though. That's more difficult. There are new therapies for calcium, and some people, it's something that's so new. Like people are using these peptides and these exosomes and all this. I'm sure you guys are in that too, to remove calcium. I'm not sure that works. I don't know. But when you see calcium in a blood vessel, you shouldn't have calcium in the blood vessel. It can be normal aging too, but you see these patients with coronary calcium scores of 1,000, 2,000, 500. That's a lot of calcium, and they will have it in their limbs also, and even their brain, but we hardly ever check it. Okay, next slide. Okay, let's go to the next one. It's pretty boring. Risk factors for ulcers. Okay, so most people with PAD are not going to get an ulcer, and that's kind of the amazing thing, right? In fact, most people with atherosclerosis are not going to have a heart attack. They're not going to die from the atherosclerosis. But there are some people that are going to get. It is still, and this amazes me because we're post-pandemic, right? So even after the pandemic with COVID and everything we got going on, the number one killer is still atherosclerosis. This phenomena of inflammation in the blood vessels, wherever it is, in the brain, in the abdomen, in the heart, in the legs, whatever. It's the number one killer. It's more prevalent than all the cancers combined. Okay, I always I see the patients in the office, the women in particular, because women are very good. They screen. Women go in, they get screened. They go get their pap smears, they go do it, and they don't get screened for heart disease. Their first screening could be when they have their heart attack. That's not screening. Or when they have an ulcer, or when they have whatever vascular problem. That's not screening. That's actually end stage treatment. So it's important to screen. Now, how do you screen for PAD? The nice thing, this is one of the good things about PAD. Most of the blood vessels are outside of the body, or not outside the body, but they're not in areas they're in areas that can be seen. Okay, so something really simple like an ankle brachial index. Okay, anybody can do it. Anybody can do an ankle brachial index, and it's a pretty reasonable tool to diagnose peripheral vascular disease. Now, at our office, we do a lot of one of our niches is we use artificial intelligence. We use it for our coronary CAT scans, and it's amazing what you can do with AI. We're doing things that I never thought would be possible 20, 30 years ago. One of the things that we can do with AI in the office is there's an algorithm that can check you for endothelial dysfunction. Okay, so it doesn't hurt. You don't have to stick a needle in anybody. In the old days, they were basic tests. It's very uncomfortable. You can use an algorithm. It's basically a pulse oximeter with a blood pressure cuff. Okay, and it's got an algorithm. When I first saw this about 10 years ago, it came out of MIT, and these guys came up with it. And it doesn't work, man. And I just thought, we'll use it. It works. It actually works. If you train, and you don't have to have a PhD running the lab. You're gonna have just normal folks. You train, and they can check for endothelial dysfunction. So there's almost no reason not to check for it. Okay, so that is a marker of vascular dysfunction, and there's just people walking around with it. And that is a very, very. It's not just that you're checking biomarkers for inflammation. You're actually checking for dysfunction of vascular tissue. So a lot of patients walking around with that. So when you see that kind of thing, you see endothelial dysfunction. And the endothelium is the lining of the blood vessel. If you were to take anybody's, and people argue, what's the biggest organ, right? Well, it's probably vascular, because if you were to take just that sheet of cells that called the endothelium, that is the inner lining of your blood vessels, you would be able to cover about 2 tennis courts. Okay, it's a lot of tissue. Okay, it's just very thin, and it's very vasoactive. And a lot of people, and there's actually been Nobel Prizes awarded for people understanding how the tissue works. It's a very important part of tissue. So when people have vascular dysfunction, when they have a non-healing wound, they have erectile dysfunction, they have other vascular phenomena, they're having endothelial dysfunction. Now, and the beauty of screening for endothelial dysfunction is that you can check people very early. They don't have to have, by the time you get to see somebody like me, man, you got a 90% carotid stenosis, you got a black toe, or you're going for heart surgery. You don't have to do that. You can check for endothelial dysfunction in somebody that's just screen. Just screen. Check them, and they have it, and then you go, oh wow, well, hey, your homocysteine level's 22, and your A1C 7, and maybe we should, you have a metabolic injury, okay, and it's harming your endothelium, and maybe that's why you have erectile dysfunction, maybe that's why you have hypertension, and then you help the client, the patient, I joke around a lot because I always tell my patients, well, how, you want to take away, you want to give me business or you want to take away my business? You want to learn how to do that? And you can't do that with everybody, right? Because I mean, the healthcare system isn't really set up for that. It's set up for medicines and operations, right? We know that we're all kind of colleagues in this, and we know this, and we're in the system. We have to work with it because we're not gonna fight it the whole time, right? We gotta work with it. But I think at the same time, we have to be aware that the system is that. So when you're trying to help a client, a patient, you have to tell them, hey, man, I get paid to operate on you and to give you medication. Like, you want to get out of that? No, I'm cool with that. Okay, cool. But some of them are like, yeah, is there like a back door for that clinic? Like, yeah, there's a back door. And then you can teach them. You can't do that for everybody, but you do what you can. Let's see the next slide. Let's see. And I did some notes. Anybody do chelation? No? Okay, yeah, this is cool. Because, like the plumbers, right? Because, yeah, we're really good at plumbing. We have a lot of tools for plumbing. We have drills, we have ultrasounds, we have lasers, we have we have drug-coated stents, we have drug-coated balloons now. We have a ton of technology for revascularization of lower extremities. Now, works really well. I would say in the pelvis and the aorta, which once you start going kind of down the distal SFA, I mean, yeah, everybody's got their toys that they like. They're not that. I mean, you've seen these patients, right? They get revascularized. I mean, the artery's not going to be open 3 months, a month, 4 weeks. So the goal is very different. It's just to give April more blood to that area so that she can have an opportunity to heal that wound. Because it's only one factor, right? It could be a powerful factor. So things like chelation, and this, I got sidetracked. So there's actual papers that show that if you do chelation on these patients that have terrible diffuse vascular disease, they do better. They do less limb salvage. Why don't we do it? It's just the business model. It actually works. How does it work? It's very interesting. Probably heavy metals. You're probably chelating heavy metals. You're probably chelating cadmium, mercury, who knows what else. I don't know that much about it. I'm always looking for people that want to do it. There's a few people, I think, actually in Mexico, mostly across the board to do it. So that would be something interesting, I think, that we could do here, do some sort of chelation clinic for this kind of thing, especially for people that have diffuse vascular disease.
So with that idea, we're having this live on our new category that is our YouTube channel and our Facebook Live, and we have a show now. If you do chelation anywhere throughout the country or the world, and you're having effective, I'm sure there are clinics in New York, somewhere else, not here. Reach out so we can network with you because we want information on that. This is a very important thing. More importantly, I'm always looking for things that I can do to me.
Yeah.
So red light therapy, I want to give me. So this is the reason why. Let us know if you do chelation.
Yeah. Anybody doing ozone? Yeah, ozone's interesting. It's 3 oxygen atoms put together. So Nikola Tesla figured that out. 100 years ago, he made a coil. You can O2. I'm going to give you guys kind of the way it's the reason people don't like to use it, at least people is because nobody knows how it works. And if you want to kill something in our medical, because I mean, we're like obsessed with how things work, and that's so something we don't know how it works. Even if it works, we don't want it, right?
We're talking about it the whole conference, right?
Yeah, it challenges our view. Yeah, it challenges our view of.
You have a brain to think, right?
Well, that's why you have a brain to think. Well, forget. I mean, it's just observation. So ozone, people have been using ozone for 100 years or more. And it actually works. You can make the O3 now. You don't want to breathe it because it's toxic, just like water. You don't want to breathe it because you're going to drown. But you can use it for wound care. You can use it for healing wounds. You can use it to disinfect. It can be quite powerful, and it's also a chelation agent. That's why I bring it up. You can use it intravenously as a chelation agent. Definitely not FDA approved. Some of the other ones are approved. So whoever's going to go into this, whichever brave entrepreneur is going to get into this, you have to be aware of that. But there are people like me that will, probably help. It's not, it's a service to the community, right? And like April said, I mean, maybe you're not going to help all your clients with it, but maybe you're going to help me with it. So sometimes I do it for me. I'm like, man, I want to do it for me. I want somebody to have it so that when it happens to me, I have these opportunities to do something less toxic or something that can help me rehabilitate quicker. It doesn't have the risk of some of the stuff I do. The stuff I do, I have a license to do very risky stuff. That doesn't mean that's where I'm going to go first. Okay. Any questions about that? We're kind of going all over the place with PA. This gives you an idea why this is so complicated, right? I mean, you guys are in a wound care complex. You guys are used to complexity, right? The PAD arena is very complicated. That's why it's all over the place. Okay. The revascularization part, I think, in my mind, is the plumbing part is the easy part. It's really not that difficult, especially for somebody that works in the heart and the brain, that kind of stuff. Okay. Let's go to the next slide. Let's see if we can see something interesting. So risk factors, I think everybody knows about these. Let's go to the next. Okay, they're talking about ABI. They're talking about the transcutaneous oxygen pressure. You guys are doing those? See, we don't do those that much.
Yeah. We don't do those in our clinic, but where are they doing TCPs? In the hospital setting?
Yeah. Usually I see them with the podiatrist.
Oh.
Some of the podiatrists like this.
Is it in the clinic?
Yeah, they'll do it in the clinic.
I probably should have it in the office, but I usually send for regas and all that good stuff. I have an ABI.
Yeah. See, I don't do wound care, so I usually don't. I know what it is, and I know some of the podiatrists use that as a pretty powerful marker.
It is a wonderful.
Yeah, and the point here isn't to know every single marker, because I think there's too many things. The thing is to find the ones that you know that you are good at and use them, and then obviously know somebody in the community that uses other markers, and because you're going to get stuck, you're not going to be able to help everybody, right? But then you call somebody else and hey, what do you think? Well, I use that client, that patient will do better with that approach, right? That's why it's good to have community. That's why I love what April's doing, just getting people together, talk about this. And let me know if I'm going over time, because I could keep talking for a while. Okay, next slide. Yeah, so basically refer. Next slide. We talked about cholesterol. So statins, you know, when I was in training, the statins came out, the cholesterol medication came out probably in the 90s, not so many. This is when the work was being done at UT Southwestern, and then the blockbuster drugs, they came out, and, multi-billion-dollar industry. In the beginning, I mean, in the community, for lay people, it's still kind of a conversation about cholesterol. But really, the vascular guys, we know that cholesterol is not really it. It's really inflammation. Now, why do the statins work then? Because they're anti-inflammatories. That's probably their mechanism. Okay, they're kind of, now, are they great anti-inflammatories? I mean, they're okay. Like, I use statins. If I have somebody who's unstable, like they're coming in and they're going to have a vascular procedure, legs or anything else, yeah, I think they're helpful short term. People are just left on them forever without really addressing the inflammation. That's not necessarily what I want to do for me. It's kind of like what I was telling you guys, but that's what happens. Okay. Now, are there other anti-inflammatories? Yes. There's some work, for instance, like things like colchicine, aspirin. Everybody knows aspirin is an anti-inflammatory. The drugs usually, statins are maybe the most successful in that arena for atherosclerosis. Although the rheumatologists have a tremendous arsenal of anti-inflammatories or medications that suppress your immune system, which are very toxic. Okay? You can't just shut down inflammation with a pharmaceutical and expect good results. So this is where we kind of get back into the whole lifestyle. Patients come in, they're smoking, and I still see it. Actually, although I like my smokers are more predictable. For vascular, they're very predictable. They quit smoking, they usually don't need. They'll need me for one or two procedures, and then they're good. You know, the patients that are most difficult, in my opinion, are the ones that come in and I can't tell why they're inflamed. I just can't tell. I can't really put my finger on something. Those patients have something in their environment or maybe something they're doing. I mean, there's even studies of people activating their inflammatory system through trauma. I mean, it gets very complicated. Okay, how are you going to? I mean, as an allopathic doctor, where am I going to do that? You know, I don't have the infrastructure to work with that. Okay, so inflammation can be very, very, very complicated. Well, I mean, you guys, you know, when I first heard that, I thought, no, that's crazy. You guys, there's some studies out that show. Are you guys familiar with split personality disorder? It's a real thing. It's a real diagnosis, right? People actually have split personality. Very rare. Well, it happens. It's extremely rare. There's been movies about it, and it's kind of creepy, right? Yeah. Well,
tiene gato.
People, yeah. People. I'll get to the point here because this is a vascular talk, right? But I wanted to make it fun because I think talking about stents and wires and all that.
Es que me ponchó el carro
We
y
can show you,
se le salió la llanta al
it's
ring.
not that interesting. The split personality. Yes, people have personality disorders, but that's not split personality. Split personality is when you are actually another person and you do things and you don't remember what the person did. It's a DSM-4 or whatever. It's a real thing.
Lo que pasa es que yo estoy trabajando ahorita.
Yes, very famous movie.
Terminé como a las 4:30, 5.
It happens.
Pero acá ando en una conferencia.
Yeah, and not that you have to watch it, but.
¿Te hablo cuando salga o qué?
Yeah.
Órale pues.
Yeah, but so this, and I thought, oh, this is psych. What does that have to do with vascular, right? Who cares, right? Well, get this, guys. You can have in these people that have split personalities, one person can have an anaphylactic reaction to peanuts, and the other one nothing. Yes, one person can have a different blood pressure than the other one. One person can have a different ocular pressure than the other one. Yeah. So what does that mean? It means yes. So it means that the inflammatory response can be activated by you getting a divorce, by your parents dying, by having losing your job. You know, we talk about all kinds of stress. Yeah.
There was also an article about PTSD.
Yeah.
Mm-hmm.
Into what?
PTSD.
Absolutely. Yeah.
Cardiovascular.
Absolutely. Absolutely. I see. Absolutely.
Higher LDL levels.
You check these patients, high sensitivity, C-reactive prone, they're very high. I've seen a lot of people, we see a lot of people from the VA, and young, I mean very young. We're talking 40-year-olds.
And they relate it to PTSD.
Absolutely. You can activate your inflammatory response. I mean, now, oh, Dr. Gomez, that's good. It's not controversial. I mean, people have done it, they measured it. Are we acting on it? I mean, when I put a stent in, we should be. I mean, yeah. And I'm kind of throwing this out there to make it interesting and just data. But sometimes I'm putting a stent in. I'm like, well, I mean, this guy has PTSD. What's that going to do? Nothing. It's going to buy him a little time so he doesn't have claudication. Okay, but I'm not really fixing anything. Okay, even though we do it well. Absolutely, these things are toxins, and there's preservatives. There's preservatives in the alcohol. The FDA does not monitor that. So the alcohol makers can put whatever they want in there. Okay?
They do all these studies on tobacco use.
This Roundup, what's the chemical name for Roundup, the pesticide? Well, does that give you atherosclerosis? Probably. Yeah. I mean, there's a bunch of stuff. Okay. I mean, we can get into it. But let's go for low-hanging fruit, guys, because it's not like we're going to move to wherever there's nothing, everything's perfect, right? We live here. Yeah, let's move. Yeah. So what I'm saying is let's work with what we got, right? So something like trauma. A lot of people could do PTSD treatment, or go get a therapist. And, teach people to downregulate their inflammatory response. Okay. There's this guy I'm sure you guys have heard of. This crazy guy. They call him the Iceman, Winhoff.
Oh, yeah,
Yeah, anybody read the book? Okay, well, the Winhout method, right? It's an interesting book. Well, one of the things that like blew my mind when I first read it years ago is that this guy went to the University of Pittsburgh medical school because I guess they thought he was like a freak, right? Because he could like last in ice for 20 hours or whatever, which is crazy. And he would say, no, I just train and everybody can do it. Okay. So they said, well, I wonder what else he could do. So somebody got the bright idea to inject the guy with endotoxin and see what his inflammatory response would be. You guys know what endotoxin is? It's that E. coli that kills you. It gives you sepsis. Well, they can isolate the toxin in like small amounts of poison, right? But people have big time inflammation. Nothing. The guy would will himself into not having an inflammatory response. Well, he trained. Okay? Trained. Now, you can say, oh, he's a freak, and only he can do it. Well, look, we all come from the same species. We're all human. We're not even that different. If you look at our DNA, it's kind of the same. We have a few little things here and there probably different that give us different height and different eye color and that kind of stuff. But for the most part, we're not that different. If you can train your body to lower the inflammatory response. That's the point. And are you gonna get less atherosclerosis? Probably. Okay. That's why patients, they come and see me and they're like, man, I've been going to the doctor since I was 40 years old. I've been on a statin. I've been taking aspirin. I've been taking my diabetes medicines. I've been doing this, that, and why do I need heart surgery? Because it's not the only thing. You're not just gonna address this with a pill, okay? Now, lifestyle is a very kind of everybody throws it out there. It's not just eating salads. Okay, lifestyle is way more complicated than that. We just talked a little bit about that. Well, how do you control your emotions? How do you control your inflammatory system? How do you control your response? It's complicated. It's more complicated than this talk. Okay? Easy, like I said, the easy part is the plumbing, the revascularization. That's the easy part. It has to be done correctly. It has to be done well, but it's not necessarily the most important part. Okay, let's see what else I got. And revascularization. Yeah, refer early. Yeah, find somebody you like. Refer early. Find somebody who's competent. Refer early. That usually works. Because let's say even you have a complication. Well, then they will refer somebody that's high risk cases. Right? So you're always better off referring early, assuming the patient is competent and is not doing unnecessary procedures, right? Which you guys can get together and figure out. Right? Let's go to the next one. Amputations, we talked about that. Next. You do better without getting an amputation. That's basically it. Next. Okay, let's talk about venous. Let's cover one more topic. Or we can talk about venous, or we can talk about anything else. Anybody want to talk about anything in particular?
I want to talk about venous, Doc.
All right.
And then you pull up the venous ulcer.
Yeah.
Tell us about venous ulcers. I want to say about venous ulcers, they're darn hard to treat. Patients have chronic hemosiderin staining. They've already been with this venous ulcer for a long time. They've had venous issues for years before they ulcerate, but as soon as you see it, they can ulcerate at any second. They're very hard to treat. It's a multidisciplinary approach, and I would love to hear about your venous treatments.
Venous is I really enjoyed doing venous work. But just to give you some background, when I was in training in my vascular fellowship in 2000, más o menos, there was no venous training. Nothing. Anywhere in the country, really. There was no venous training. I mean, the extent of the venous training was basically getting venous access, putting pacemakers, IVC filters, that kind of stuff. I mean, there was really no venous work. Now, the field has kind of taken off. It's a little bit like KD, where it's kind of like it's a little bit of the Wild West. Even when you go to the conferences, it's a little odd. It's not standardized. Everybody's kind of doing their own thing. We do a lot of venous work. It's complex, and you really have to know when not to do stuff. because as an endovascular person, I think one of the temptations is to put things where they shouldn't be or destroy things that shouldn't be destroyed. In the venous stuff, sometimes you just better leave it alone. But those cases, that's why I like the wound care cases, because there's a lot of work to do in the venous cases. Okay, one of the things that I think, and April can tell me if I'm right about this, but one of the things that complicates these venous ulcers is there's just a lot of pressure on the skin. I mean, there's a lot of swelling, there's a lot of pressure, and of course nothing's going to heal when it's being pressurized. Okay, it's very difficult to heal, and it's being pressurized because there's an issue with the venous system draining into the heart. Okay, the venous system is very repetitive. We have a lot of veins. We have more veins than we do arteries, and also the venous system is very dynamic. One of the things I had to learn the hard way is when I'm doing, because we do a lot of inferior vena cava work to revascularize the inferior vena cava, revascularize the iliacs, the big veins. Big veins do not act like arteries. They do not. They're very dynamic. The shapes are not always certain. The stents don't fit. You really have to, it's more of an art. And they have specialized equipment for it now, but just recently we were still using kind of arterial systems, which don't really work that way. Okay? So most of the time when we see a case like this, when you send me a case like this, what I'm looking at is, okay, how can I decrease the pressure to that venous system? That's really the question I ask myself.
I'm going to interject for the people watching. Can patients get venous stasis in their abdomen?
Yes.
Okay, this is something we don't want to talk about because it's very uncomfortable to talk about it, but we've spoken a lot about obesity. And when you have this right here, I had it. You have this pancita that is putting pressure here, putting pressure on everything. You don't move around and you're in a wheelchair now, and you have more pancita because you're eating more, and all that pressure is putting pressure. You're sitting down in the wheelchair, you have more pancita. So patients coming in a wheelchair with a huge venous stasis ulcer, and I'm like, you need to, whatever you're eating, you need to cut it in 4. You need to have 5 meals out of your 2. So talk about.
Look, this is a really important topic because I get a lot of patients that come to me get referred for venous stasis, and they're morbidly obese. I mean, so the first thing I tell them is, yes, you have veins that are malfunctioning. You have valves that are not working. But we gotta get the pressure off of you, the external pressure. There's a lot of, because remember, the veins don't have the pressure of the artery, so they get compressed. So obesity is a big, and so I will not work on at least a cosmetic, for sure a cosmetic case, I will not do it. It has to be like a venous ulcer for me to do it, but usually I will say, hey, go lose 100 pounds, 50 pounds, whatever, work with the bariatric surgeon, work with the weight loss clinic, whatever, come back. 50% of the patients don't have a problem after that.
The other 50 don't need it.
No, well, let's say, okay, let's just tell you, the other half, más o menos, they still have the venous issue because they blew out the valves, because they injured the vein, and you have to help them. Okay, so then we do revascularization of the venous system, and they do that. Okay, but usually it's like let's get that weight off you. Now the other thing that's really that happens a lot is one of the things that, and it has to do with obesity too, but not so much, is people have a lot of inflammation in their musculoskeletal system, their spine, and one of the things that happens to us as we age is we shrink, right? Shrink a little bit, the spine. So what gives, bone or vein? Vein. Okay, so a lot of times we're doing this venous work, and it used to surprise me in the beginning. Now, I get it now. I'm actually moving the spine, I'm moving a joint, I'm moving a bony structure with the equipment to revascularize, because it's squashing the venous system. So these older patients, they tend to have a lot of obstruction. It could be spinal or in the pelvis or some type of bony structure. Okay, or the arteries doing the compression. We call that May-Turner syndrome. Okay, but certainly obesity is one of those things that has to be addressed in these patients. Yeah, because I mean, in the beginning, I mean, okay, yeah, let's treat morbidly obese patients with venous stasis. I mean, as long as it's not an ulcer, I think it's good. You know, you can wait. You're not going to have a happy patient. They're just, it's not going to have, you're not going to have plus these patients are high risk for DVT. Okay, so if you put metal in the vein, guess what's going to happen? You're going to get a DVT. Okay, now instead of having just venous stasis, now you got a DVT on top of that. Okay, anybody know what the mortality is from acute DVT? From a DVT turning into a P, what the mortality is? 25% sudden death. Now, I mean, it's not just a edema issue; it's a life-threatening issue. Okay. What else with the venous system? There's a lot of people. The venous system is one of those areas too that everybody's doing. Cosmetics, chiropractic, practors. I mean, again, I have nothing to say bad about any practitioner. It's just everybody. I mean, you're not going to see me delivering a baby. Okay, it's just probably not going to happen unless it's in a taxi. It has to be done. Okay. I'm just probably not going to do it. Okay. Everybody's got to kind of do what they do best. And the venous work is very complicated. I have seen, for instance, I had a patient not too long ago that was a power lifter, border patrol agent, and had swelling, a lot of swelling. And she went all over the valley getting venous ablations because they're cosmetic, right? So they go in, they laser your vein, they get rid of the veins that are harming you, right? Well, it doesn't really do anything if you tore your iliac vein squatting. You actually are draining the leg. So every time you do an ablation, the leg's going to get bigger and bigger and bigger. Until they got so big, she ended up in my office. Okay. By then, we have to revascularize the inferior vena cava and the iliac. And we had, and then she kept lifting, and so she clotted it, so we had to actually bypass it. Not an ideal case. Swelling. Lots of swelling. Yeah, lots of swelling. Oh, she had an ulcer. That's right. So yeah, I mean, yeah, and then powerlifting. I like strength training. Who doesn't, right? I mean, I think the more muscle you have, your mortality goes down. All-cause mortality. However, it's an extreme sport. Okay, not all exercise is the same. Some of it is not exercise. Some of it is extreme sport. So these athletes can tear the venous system. I've seen it in the arms. I've seen it in the legs. They will just tear it. Okay, and you have to revascularize it. Going and doing an ablation, like in other words, burning the congested veins, is not going to help them. Okay, so you have to be careful. We all have our place in this world. Right? Sometimes we say stay in your lane. I hate to. Sometimes I get out of my lane too, so it's okay. But venous work is challenging. It's very challenging. Would you say that? I mean, when Ismail came to our office, did you guys do any venous work? Did you? No. It's quite challenging. It's quite challenging. And Ismail has. I mean, you got more than 20 years clinical experience, critical care, and cardiology. Okay, so it's difficult to do venous work. It's not for everybody. Okay. It's very forgiving in the sense that you don't usually. I mean, the complications are, but that doesn't mean you don't harm the patient. So you do. It has to be done well. With that said, I think we've talked about it. Anybody have any questions? Anything else you guys want to talk about? I'm so happy that I got invited. Thank April for having this.
Little pro I want to mention about venous, for those of you with primary care. You see a venous ulcer, you're going to order venous stoppers. Most of the time, you're going to see no DVT. That is why we assess for venous insufficiency.
We're going to say that again for the video.
For those of you that work in primary and wound care, whenever you suspect a venous ulcer, you order venous stopper. If you don't specify for venous insufficiency, it's just going to say DVT, and some people feel that implies that the venous system is okay, and a lot of times it's not. So, I mean, you don't have to do that, but when you send it to a vascular specialist, that's what we do. We do a venous stopper for venous insufficiency, which is very specific. The reason they don't do it in your average imaging place is because it reimburses the same whether you do a venous stopper DVT or venous insufficiency DVT. The tech is probably going to charge you the same for that study, whether it's DVT or venous insufficiency. But the DVT test takes 5 minutes, and the insufficiency takes 25 minutes.
Yeah.
So you're gonna send them to a venous very swollen, and no DVT, and a lot of times that gives a false impression that the venous system is okay. And it's really not.
It took us a long time to train our techs because the venous studies are very difficult and they're now well reimbursed. I mean, they're not. So what happens is there's not an incentive to do a full study. So they, you guys have seen that even with DVTs. They stop here, and the DVTs in the calf, right? Well, with the venous reflux, like Ismael was saying, it's even more challenging because there's a lot of veins and you got to do a Doppler study. So you're going to get a negative study, but they have a ton of congestion, a ton of reflux, and it's going to be normal. That would be one, and they can happen to you at the hospital too. Not because they're not good techs, it's because that's not what they're looking for. I equate it to looking for a needle in a haystack. Looking for a needle in a haystack is tough, but if you've never seen a needle, try that. Okay, that's going to be very challenging. If you at least know what a needle looks like, you know what you're looking for. So when you're doing a venous study, you got to know what you're looking for. And a lot of times you're looking for reflux. You're not looking for DVT. Reflux is way more difficult.
So I've learned to specify. I told my kids that I put venous insufficiency study. If I don't write that, they know I'm just looking for DVT. So kind of helps.
And the techs are good enough now that if they see somebody that has obvious reflux, they'll document it for you.
They may or may not, depending on where it's at.
Yeah, depending on at least our guys. But that took a long time. Yeah, to get that down. Yeah. Okay, well, thank you guys.
So guys, the pro for that one, so many pros, right? First of all, the progressive, forward thinking, the preventive, the wellness, the health, the holistic, all of that, keeping up with all the newest stuff coming out. And what else can you do for me? I keep talking about my knee. Everybody goes to ortho. I need to do a full knee. No, I had all conservative, red light therapy, massage, healing, a lot of supplements, proper therapy. So of course prayer. Those things matter, and you want to keep up with the latest treatments. The pro, I don't want to forget about this for all of us that are practitioners that prescribe and treat and order tests. My takeaway is, okay, I'm already going to do an ABI, I might as well do the carotid ultrasound. If I know I have CAD, like we always do them, but I said a reminder. And then if I'm going to order for rule out DVT, I already know the patient has a venous issue, so might as well already order for looking specifically for venous insufficiency, because we don't know that they're not doing it.
Another thing we've learned as a pearl, I think, it's important, is when you refer for venous work, make sure that the operator knows and understands how to use intravascular ultrasound. It's critical. It's critical. You cannot just you cannot base your revascularization on just injecting like you would in an artery, although even that's questionable. You have to really understand ultrasound, intravascular ultrasound, to do the work, and not that will not happen anymore. Not every program will do it.
So
I want all the pros.
That's an ultrasound. It's inside the vein. It's inside the vein.
How do you?
And when you put in a venous system like that, well, to make sure that whatever intervention
Especially in the pelvis,
it is well approximated to the wall. Yeah. The veins are very malleable, and if you're dehydrated, they're going to look smaller. So if you just size a stent and the vein is not, it's
but even for the diagnosis.
Yeah.
I mean, besides the stent, the operator needs to understand how the technology works.
A lot of people don't do it.
And it's not standardized. Not everybody does it. People just, it's a 50%, let's stent it. Well, what happens there is these are big stents. There's a lot of metal, and now you have metal in the vein. I mean, look, they're probably, if they put it in right, at least it'll get covered up, but not always. So now you have a piece of metal in a vein. It's just exposed. So the patient's going to have to be on antiplatelets for a long time. Okay? So if you're going to get revascularized, make sure it's done also with intravascular ultrasound.
Yeah, and the reason veins are such a popular subject right now is if you do them in the office setting, they're actually very lucrative. So a lot of people are doing them. So what might happen in the situation that Dr. Gomez was speaking about, you get an ultrasound, you see reflux in the GSV, and they tell you, hey, we can ablate it tomorrow. But you don't know, and that's walk out with a Band-Aid, it's done in the office, and reimburses really good, but you don't know if that person has actually pelvic compression, which is in the deeper system. So if you knock out the middle vein, the reflux wall, without checking the deep venous system, all the pressure from the deep venous system is going to go to the superficial side.
Well, the patient's actually using that vein.
Yeah, you're going to make it worse. So you're going to see some. So it's all little buckets and pressure. So protocol, you do venous insufficiency study. If there's reflux, then the next thing is a venogram. See, there's pelvic compression with IV ultrasound. Maybe
Sometimes we go in there and the vena cave is completely occluded.
Yeah.
Oh, yeah. You
You
don't
gotta
do an
fix
ablation.
that in there.
Don't do an ablation. Yeah, bad idea.
That's a pro right there. For all of you watching, if you're going around just removing your little extra varicose veins and everybody's ablating you, there's so much more than that. That's why I always like when something new comes out, oh, we now have this that we can inject and let me see how it goes for the next 40, 50 years. I'm not gonna put that, I worry, so like, go to the experts.
I mean,
we always focus.
It's just a proper
Right.
way for yourself.
There's a time, there's a time to act.
Just like primary care.
Well, but our philosophy is, if we don't know if it's going to help you, we're not going to do it. We have to be. We can. Sometimes we're not 100% sure, but we're like, yeah, this is worth the risk, okay? But there's some cases that flat out, well, we're not. No, this is not going to help the patient. Why are we going to do that? It doesn't make any sense. Even if there's like some sort of indication, even if there's a vascular indication, it's not going to help the patient. Don't do it. And don't put in foreign objects where you don't need it.
Thank you, doctor.
Thank you very much.
We appreciate it. All of you watching, thank you. I can't believe all these people are still here. My God. I want to do a little light on the vendors that are here, or did Lisa go already? Did you check out your food already? Okay, but you want to talk about, oh wait, where's Olivia? Oh, okay. She's not going to talk about it. It's okay. She's like, I'm not going to come out to public speak. I don't like it. Thank you so much for being here, guys. Everybody who stayed on for the live feed. Everybody who came. I haven't eaten. I don't know if there's a sandwich for me that I could just have the inside. If not, no, vamos a comer. Oh, no, that was I can't have it. Pura pasta y pan. I was only going to eat the inside, though, whatever was inside. Thank you so much, guys. Next year, I'm already going to announce it, and I already booked it, okay? September 14th, 2024. Primero, we have it. All of them, I can't believe you didn't let me get booked. It was so fast. But thank you, everybody who came. If anybody wants to come out and say hi, we're going to do like a few shots here. I want to introduce my team to you. Meme left already. Michael left already. But Dee is like my little sister. Hey, Doc, thanks so much for coming. She helped me build the company. And Marco is my fiance. He's running the wound care, all of the billing stuff. So he's the boss man. Hey, Mikey. And Michael is like my son. He does a little bit of everything, front, back, and everywhere. And he helps me with my kids. So he went to get my daughter. Say hi, Mikey.
Hello, everyone.
So we can't do what we do without them. And then Meme, and then we have Terry that's not here today. So we are very blessed. Please take the shirts. I think we did because I was able to do my slides, so we did them all. Right? We did them all. Amazing. Hey guys, thank you so much. Any questions? If you have any questions for me, I'm gonna be hanging out for a little bit. Any questions about any specific cases? Something that we didn't cover? Anything? We're good? Okay, very good. If it's wet, you dry. And if it's dry, you wet it. Okay, thanks for coming, guys.